Best, give your best smile and best your smile and 3, 2, 1, go. Say cheese. Oh, unggul. Thank you, everyone. And okay, without further ado, let us begin with our first topic, conducting behavioral and clinical trials in the real world, which will be guided by our moderator. Allow me to briefly introduce him by reading his curriculum vitae. Our moderator is Chandra Dwipayana Hamdin, PhD. He is Assistant Professor, Department of Pharmacy, Faculty of Medicine and Health Sciences, University of Mataram. Our moderator, academic background, graduated in Bachelor Pharm in Pharmacy 2012, also Magister Science in Pharmacy 2014, and PhD in Biomedicine in 2024. And our moderator had a more experience in publication our projects like IDSF 2025 with title Evaluation of Bursia javanica extract on vascular stenosis post-endothelial denuration and more experience in community service in 2024 and 2025. We kindly invite our moderator, Apotheker Chandra Dwi Payana Hamdin PhD to lead this session and let's give a warm round of applause.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. The Honorable Guest, all guests, respected lecturer, Dr. Agus Dwi Ananto, as a chair of the committee, our invited speaker, Dr. Sukri, and all participants joining us on site and online. Welcome to today's guest lecture on conducting behavioral and clinical trials in real world and writing for the international journals. It is a pleasure to have all you here today. This session is designed to provide practical insight into how research is conducted beyond controlled academic setting, particularly in real-world clinical and community contexts. We will also discuss on how research findings can be developed into strong manuscript for the international journals. My name is Chandra and I will be moderating today's session. This guest lecture together two important aspects of academic and health research. First, we will discuss on how behavioral and clinical trial can be conducted in real-world setting, where research often involves actual communities, health system, and field conditions. Second, we will also discuss on how research finding can be prepared and communicated through international journal publication. Through this session, we hope to gain theoretical understanding and practical insight from research experience. Before we begin, allow me to briefly introduce today's speakers. Our speakers today is Dr. Mohamed Sukri Zawahir. He is a research fellow and senior clinical trial operation coordinator at the University of Sydney, Australia. He has more than 20 years research experience, teaching experience across Australia, Sri Lanka, Vietnam, and Malaysia. His academic areas include clinical epidemiology, antimicrobial resistance, pharmacy practice, and clinical trials. Dr. Sukri has also published in leading journals, including the Lancet Regional Health, the BMG Global Health. He has produced more than 20 peer-reviewed publications and delivered for more than 50 international conference presentations. With this background, Dr. Sukri's expertise is highly relevant to our first session, particularly in understanding on how behavioral and clinical trials are planned and conducted in real-world setting. Please join me in welcoming Dr. Sukri Zawahir. If everything is ready, then Dr. Sukri, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh and salamat pagi. Once again, thank you so much for this opportunity to discuss. I rather say this is the continuation of the last lecture we had a couple of months back, I think in October. So it was like clinical trials or advanced clinical trials. Then today we are going to discuss about operational part of the clinical trial. In our last lecture, we discussed, theoretical part, how we plan, how we develop the protocol or proposal for clinical trials. Today, this is not more about theory, but when we are conducting the clinical trials, what are the challenges? What are the things we should consider? And what are the differences from actual theoretical perspective of clinical trial and actually when we are conducting the clinical trial? So I'm going to give some examples while we are talking real life example based on one of the trial we have been conducting in different countries, including Australia, Vietnam, and other parts of the world as well. We call it asteroid trial. This trial is a phase 3 clinical trial for TB prevention. So we have been doing this trial for last 4 years. So far, we have recruited about 1,600 patients across 12 countries. So we are managing this trial in Vietnam and Australia. So based on this trial experience, I will be giving some examples while we are going through the slides. Second thing is this trial is again phase 3, but open trial, not blinded, right? Open trial. Yes, next slide, please. All right, so this is like a quick recap. Like last time we said we try to understand what is clinical trial, and then the important parts or features of clinical trials like is a comparative trial. So if you want to see effectiveness of a drug or an intervention, we should have a comparator. So it's always comparative trial, and then randomization, and then double blind or no blind or triple blind. So we have discussed in details. So, and as compared to all the epidemiological research methods, we believe the clinical trials or randomized control trials are kind of robust model which we can implement, which we can do, and then make a robust decision on effectiveness of some intervention. So before starting to understand whether you are with the same page with me, could you tell me why we call RCT, randomized control trials, are kind of superior or robust method of research when we are either evaluating a behavioral outcome or an intervention? Why we call it is like a superior type of epidemiological research method?
Okay, thank you. I think that because randomized control trial, uh, we control the bias or any particular condition that can affect or bias the end result of this study. So we control the to minimize the X factor or any confounding factor that can affect our end results. First, first process. I think that randomization is
Excellent. So yeah, so that is what we call it randomized control trial. So the nature itself, like we control. So you deserve bear from Sydney. Thank you. All right. So because of the randomization, so we believe the control arm and then active arm both are like equally distributed, whatever the confounding factor, so that we believe whatever the decision we will make based on this trial is more or less bias or we can't say free of bias, but less bias. All right. Next slide, please. Right, again, this is again recap from last lecture. Like we have clinical trials in different phases, phase 1, phase 2, next slide please, phase 3. I don't want to go in detail. And then once phase 3 is done, that is a more on effectiveness study. So we will understand whether our intervention, it can be anything, whether it's effective or not. Once it's effective, then we go for phase, then it can be marketed, it can be registered if it is a drug. So once it's registered, then after some time, it may have some long-term impact. So to evaluate what are the long-term impact or adverse event or sometimes beneficial effect of over the time period in different groups, we do phase 4 trials as well. Next, please. Again, this is like a flow chart or diagram of the clinical trial. We have exposure group and outcome, and then comparator, and how we measure the outcome. All right, this all we have discussed. So thank you. Next. Right. Now, we have been telling clinical trials are very best trials, very best kind of study as compared to all other epidemiological methods. And whatever the findings we get from the clinical trials are the very kind of robust finding or something more or less biased. But theoretically it is yes. But if you look at the operational way of these clinical trials, though we have planned a study, we have very nice protocol, we have everything is in order to like theoretical perspective of the trial. But if the operation part of the trial is not followed as per protocol, as per standard operation procedures, then there will be some issues in terms of validity, reliability of the outcome of the trial. So my focus of today's lecture is what are the operational issues? What are the, beyond the theory, what are the issues we may encounter when we are conducting the clinical trials, and then how we can overcome those issues in order to get the actual expected unbiased or less biased impact or effect from that trial. All right. So validity can be, the bridge between the scientific hypothesis, we have good hypothesis, and the regulatory approvals build operational excellency. To ensure the trial remain robust, credible, and then free from bias. To overcome all these things, we have to have methodologically consistent defense against data fragility and the data integrity. And then, so we need to have some kind of technology adapted and reported standard ensure the global clarity. So next slide, please. Right. So what are the operational bias? So we plan our study very well. Everything is okay. But when it comes to the operation, there could be some operational bias, right? So let's say we have now developed the protocol. ethics approval has been granted. Now we are going to start the study, right? So very first thing, before starting the trial, what we do normally, I'm now talking about the practical way of conducting the clinical trials, right? So protocol is done, all the documentation is completed, ethics been approved, all the CRFs, all the PICF, whatever the patient information or whatever the things, everything is completed. Now, very first thing what we need to do before starting the trial. Now, for example, I will give some few clues. Like now, as an academic, as a researcher, as a scientist, we develop the protocol. We develop the questionnaires. We develop the data collection method and all those things. And we do all the things as an academics. Then when it comes to the real practice, academics won't go to the patient all the time and then do the trial or data collection or clinical trials. But there are clinicians, there are trial coordinators and trial assistants or whoever do the data collection, right? So as an academic, as a someone who developed the protocol, they know each and everything about the study, right? So, but when come to the practical situation, they won't go and do the day-to-day trial activities, but it's been done by someone else. So very first thing, what we should do now. Now we are going to start the trial. What are the very first thing we should do? We want to start the trial. So how? What we do? So I gave some background. So in operational way, like what is being done. So what we need to do? Who has developed the things and all these things, but who is going to do the actual field work or these things someone else. So what we have to do? Yep.
I think before we conduct the protocol or the study, perhaps we could try out first or measuring the validity and reliability of the protocol.
Okay.
And also we could determine the requirements for the others that will use our protocol.
Yep.
In the next study, in the study.
Yep. Okay. Actually, in real life, when we come up with a stage where ethics approval in everything is granted, is already everything is piloted. So we are ready to go ahead. So we are ready to go and kick off the trial. So in that stage, so I want to think and say practically what we must do first thing, and then how important that one. I want to emphasize that one. What is that thing? Yeah, before recruitment, what we need to do. This, yeah, of course, recruitment, before recruitment.
The inclusion and exclusion criteria.
Ethic is done. Inclusion, exclusion, we have to screen, yes, and then recruit before that. Recruit is stuff done. So after that, everything is done, but one thing is very important. That is in, sorry? Randomization. Yeah, so before randomization, excellent. That is important. We call it site initiation visit. So site initiation should be done with very, 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 very important. So each and every site individual who is working in the trial, number one, they have to complete GCP. They have to complete all the integrity related trial, human trial, and all those things. And then everybody must go through an intensive training on protocol. It is not just a cross-sectional study or anything. We are dealing with a human. We are dealing with a new intervention, a medicine or drug that may have a lot of side effects. So we call it SIV. The site investigation must be done and must be recorded appropriately. And each and every individual who is involved in the study should be trained very well and then assessed very well, and then it should be officially documented, because all the trials are monitored and registered by high authorities, for example, trial registries, and also high ethics committees and all these things. Also, monitoring will be there. So everything should be recorded. So each and every individual should go through this site initiation training, especially protocol training. Also, good clinical practice, GCP, should be done. And some other countries, they have like human subjects training, and all other required training should be completed. So that is very first things we do, right? So once it's done, and then a sponsor will say, okay, everything is done. You are ready to go with the initiating the trial. So we are now ready with the recruitment, right? So this is more on practical discussion rather than theory. So in the recruitment, first thing we are doing is like we are looking for the potential individuals or patients who may be eligible for the study. So that particular thing we call screening. So maybe in hospital setting, we have patients. So for this particular trial, we have patients with a TB infections or latent TB patients. We screen the patients with we have a list of screening criteria and inclusion exclusion criteria. Based on the criteria, we screen the patients. That is the first thing we do, right? So once it's screened and eligibility criteria is met, then what we do next? What we do the very first thing next. Without that, we can't do any trial procedures. Informed consent. Excellent. I can't give you another one. So, I mean, this one. I'm waiting others to talk. So, yeah. So immediately after screening, if the patient is eligible, so we must do informed consent. So rather I could say informed written consent. So clinical trials, verbal consent is not valid. So patient should understand what is procedures, what are the things being involved, and then informed written consent should be obtained, right? So once consent is obtained, then we will do what? What is the next with the patients? So what patient is happy, eligibility criteria met, okay, consent being signed. What is next? Yeah, treatment allocation or randomization. Very good. So lectures you want? I have more. Right. So we have to allocate the patients to the treatment group. Right. Now, critical thing. So randomization, screening, and then treatment allocation. So in this context, screening, randomization, and then treatment allocation, what are the problems may occur in practical life? So my question is, the first stage of the trial, screening, signing the consent, randomization, treatment allocation. So what are the issues we may face while conducting these preliminary procedures with these clinical trials? Okay, we'll come one by one. Screening. So I have a lot of examples. I will give few, but I want to hear what are the problems we may face or we may do, or what are the mistakes we may may be doing in screening? Any example, like what could be go wrong? In the screening process, what are the mistakes or what are the things can go wrong? Okay, based on the screening criteria, like, okay, if you want to be in the maybe a steroid trial, let's say screening criteria should be adult, should be no comorbidities, should not be pregnant, should not be a child, and then should have positive certain test, and then should not be taking any contraceptive medication. So these are some, based on the trial, there will be a list of criteria you need to screen based on the criteria. So what I just mentioned is based on the trial I'm giving as an example today. Okay, we learn from mistakes. We did a lot of mistakes in trials. So I'll come back to this one. I will give you what sort of mistakes we did while we were screening. Because sometimes clinics are very busy, a lot of patients, and then the trial people, maybe one or two are working. So maybe the queue, many people to be screened. So we quickly do the things, right? So as very smart people, we want to finish the things quickly as possible as we can. So while screening, so we miss many cases, like, we miss to ask whether we miss to check, like, pregnancy status, like, doing a small blood test or a CG test. We miss some cases, or else a pregnancy test should be done within 2 weeks, but we overlook the date. So instead of 2 weeks, we looked at like more than 2 weeks. And then chest X-ray should be screened like within 3 months, last 3 months before randomizing. So we looked at chest X-ray like that was like beyond 3 months. So these are the few things we overlooked, or in other trials, some other issues maybe. And then when we were recording, whatever we screen, we should be recorded. So when we are recording, then some mistakes can happen. So these are the human errors can happen in screening. So if these errors will happen, what is the consequences of, what is the outcome of these errors? What will happen? So we did a mistake when we were screening, and then we recruited without knowing that was an error. And then we start the treatment, everything was done. Then what is the consequences of this kind of error? Misclassification bias. Yes, that is a bias we do, or mistake we do. What is the end consequences? It's a bias. It's a process. Yeah. But by doing this bias, by error, what is the outcome or consequences of this error? Sorry? Yeah, of course. I mean, we are randomizing people. It's not supposed to be done. And within human, these things, we will end up very big issue. Like if, for example, a person supposed to be treated with certain conditions, if you don't follow the screening process correctly, and we wrongly screen and wrongly start the trial, that is a big offense. It's a big issue, right? It can be kind of, sometimes it can go like up to prison, sentence to prison. So these are big issues because we can't we can't play with the patient's life, right? So screening should be very, very, very important. So even though we are busy, no problem. Take your own time and look at, screen slowly, gradually. Take your own time without any pressure. Whatever the criteria, hundreds criteria, take your own time. Screen the patient correctly. If you do any mistakes in screening, then the consequences, number one, will be you will be in trouble, patient will be in trouble, ultimately waste of money too. Because one patient, if you recruit a clinical trial, it may cost maybe $10,000. So you are losing that patient that money too. and then you will be in trouble, of course. So it's not like a cross-sectional study or anything. You're dealing with a patient with a medication which is not proven yet. So we can't give them medication for wrong patient, right? So that is an issue with a screening, right? So then, no, most of the time, if you randomize the patients, normally we do randomization. In the past, we do manual randomization. Now we have kind of a randomization process with a computer-based, and we stratify by computer-based system and randomize the patient. Even though we randomize so that we can claim whatever the patients in each arm, like active arm and then placebo or control arm, whoever patient in these arms are equally distributed with whatever the stratified criteria we use. But my question is now, since we are using the computerized system, the bias will be minimum, but still, if we make some mistakes, then randomization can go wrong, right? This is more technical question, but when we are randomizing the patient, we use the computer system, so there won't be any problem because we have developed such a system based on age or other stratifying factors. The computer system will randomize. But if we do some mistakes in terms of human errors, that randomization also can be biased. So this is more technical, but I will challenge, like I will try to get some opinion or your input. So what sort of error can cause some inappropriate randomization? Though we are claiming our randomization process is very good because we are using a computer system, but due to our error, that can cause some sort of error in randomization or wrong allocation or something like that. So more technical, but I will try, maybe I will give 1 minute. If not, I will give some example. Any clue? Yeah, that is, yeah, an error can happen when we, entering the data in the system to randomize the patient. That is a valid reason that may cause some, for example, instead of male, if you put a female, instead of like age 50, put like a 5 or 15 or whatever, then that makes some decision by computer system, maybe this is male, but actually it's not male, and then randomized to female. Then that may violate these things. Yeah, very good. So other than that, any other? All right. Do you want to say something? All right. In pre-randomization process, like some maybe unavoidable reason or something can be avoidable. So sometime, treatment initiation. For example, we need to initiate the treatment within certain time for everyone. You can't initiate the treatment after randomizing, like for example, one person within 1 week, next person within after 1 month, 2 months. That cannot be done. Then the outcome may not be correct because whatever after identifying After all the screen done, the treatment should be started immediately. But some cases, like we had a case recently, what happened, all of a sudden, so we have our new drug that is rifapentine, that is an antibiotics for treating TB. So this one is our new intervention to reduce the latent TB regimen from 4 months, 4 months to 6 weeks. And then we had a control arm that is standard of care in Australia. We use 4R regimen, rifampicin for 4 months, right? But last year we had an issue. Last year, end of last year, all of a sudden our stock went out of stock, the rifampicin. So then we had no choice, but we had to choose our standard of care from that 4R, rifampicin 4 months, to 3HP, which is isoniazid rifampicin together for 12 weeks weekly. So this is human decision based on our clinical decision we make. Oh, we don't have 4R, we are doing 3HP. So that is not accounted in the randomization process. So we decide, okay, we'll give, if the patient is randomized to standard of care, instead of giving 4R, which is our ideal drug as per plan, we are giving 3HP. So that process, now we randomize, and then the patient get either active drug or standard of care. If standard of care, we give the standard of care, not we planned, something else. So that is not correct. So that now we are dealing that issue because we thought there are two things in this case. One is human. The patient is willing to get the medication we don't have. And patient is willing to be in the study. So if someone is willing to be, we say, no, you should not, you can't. So that is a very big challenge for us what to do. Then we said, okay, 3HP is there, the other regimen. So we can randomize to 3HP. And then we went ahead. Now this is a big case we are dealing now currently. Lot of meeting, lot of discussion, lot of arguments and justification. So these are the human things. Sometimes it's not error, but this is like a clinical decision made based on the not to delay the treatment and considering patients' need of the treatment and all those things. But though it's happening, but we violate the protocol and we went ahead and did, that was an issue. So my point here as a researcher, as a clinical trialist, whatever circumstances, we can't violate the protocol. Protocol says 4R, give 4R. So, but though we are very pity about the patient, we change the regimen and give. That is clinical practice. That is not a part of the trial. So we have to care the patient. Then we have to explain to the patient and take the patient out of the trial and treat the patient out of the trial, but not within the trial. So whatever the protocol compliance should be 100%, no compromise on protocol, 100%, no compromise. So even patient is, we concern about the patient health. Yes, we have to care of the patient, then not within the protocol, take the patient out of the protocol, out of the trial, and then treat them accordingly. So then we need to explain to the patient, these are the situation, and then that is fine. So here, what I'm emphasizing, protocol compliance is very, very, very important, though we are thinking of patients' safety and patients' care.
Sorry, Dr. Shukri, because right now I'm playing my part as a lecturer. So do you mind if I'm just walking through the room and help you to ask the audience? Otherwise, some of them will be sleeping.
Yeah.
Yeah, okay. Okay.
So, yeah.
Jadi saya akan bantu
You can't
Pak
sleep
Syukri
anymore
untuk
now.
supaya teman-teman lebih aktif ya, terutama yang PPDS karena ini clinical trial. Clinical trial itu harusnya jadi makanan sehari-hari teman-teman PPDS dan dari kemarin masih belum terdengar suaranya. Nah, Pak Syukri barusan menceritakan trial tentang apa coba? Yang pulmo. Kalau dengerin mesti tahu apa yang barusan diceritakan, trial yang terkait penyakit pernapasan. Ya, ayo ini buat siapa kuliahnya, bukan buat saya loh.
Tadi tentang rifapentin, pengobatan rifapentin untuk terapi, aduh, oh, bahasa Indonesia. Izin dok, tadi membahas tentang clinical trial dari rifapentin, pengobatan terbaru TB dengan durasi 4 bulan.
So she mentioned that you spoke about trial on rifampicin for 3 months, but what was the conclusion of what bold statement Dr. Shukri made at the end of his explanation about protocol? Somebody got what he said very boldly? Apa statement yang disampaikan Dr. Shukri mengenai protokol di akhir penjelasan tadi? Mas, tentang protokol.
Boleh, nggak boleh.
Maybe we
Check.
from maybe if it's we can actually evaluate our protocol, re-evaluate our protocol back if we think that our trial is maybe doing any harm to the participants.
Yes, yeah, you're correct. So you can start with the protocol. For example, I will give you an example later. So in anything down the line we found that is not correct they are doing, then we can hold the trial. We can upgrade our protocol and then trial. Now we are working on 7th protocol, version 7. We started four. After 1 year, we changed 5, some changes, and 6, 6.1, now version 7. So based on our learning, we can keep changing and then we can implement that changes down the line. So yeah, based on that one, so that then when we are keep changing the call and new protocol is implemented, should be updated. Now, what are the errors can happen in terms of patient consenting with these changes? So what are the errors could happen when we are consenting the patients for the trial, given that, down the line protocol keep changing from one version to other and updated, and then PICF is being updated. So based on that, what you think? What are the errors could happen when we consent the patient?
Oke, pertanyaannya, kalau kita mengubah protokol, padahal pasien di awal sudah memberikan persetujuan, apa kira-kira kesalahan yang bisa terjadi? Error seperti apa yang bisa terjadi ketika dia sudah memberikan konsen, sudah setuju dengan protokol awal, kemudian kita sebagai peneliti memodifikasi protokol, kira-kira apa hal yang bisa terjadi? Kesalahan apa? Ayo, ini waktunya belajar clinical trial secara lebih mendalam karena waktu itu hanya 1 jam kita berikan. Ada yang mau menjawab? Apa? Sudah setuju nih pasiennya dengan protokol awal kita mengubah di belakang. Kira-kira apa yang ya? Saya mendengar bisik-bisik di sini.
If we change the protocol, maybe there's some trust problems from the participant with the procedures, and then there is some failure to reconsent to the participant because there is always changing in the project that patient can not trust on us.
Yeah, so you are correct. So when we are changing the protocol, so we try as a clinical trial, especially, we try not to change such a way. We should reconsent the participant. Whatever the changes will be implemented for future participant. For example, I give you some example. So we change in one thing, increase enough screening so that, I mean, in like screening, so, or follow-up. So, I mean, that is already, those patients were done. So we don't need to do again reconsenting. Whatever the prospective patients we can do. Then second thing we did, like with a new version, we included the pregnant mothers and then also children under 10, I mean 10 to 12. So not 10 and above. So we, so far we have been doing for among adults. Now we included children from 10 and above. So then that is not the case of reconsenting, but whatever the prospective patient, we make these changes. And some other blood tests we included. That is also those things already passed by the previous patients. We don't need to reconsent. So no, I mean, what I want to say, whatever the protocol changes that may cause changes in the patient information, that more likely to implemented to prospective patients, not the retrospective patients, unless there's serious things we are going to redo something previous patient. But mostly we consider no reassessing or redoing the things, but prospectively we change the things. But what my question was like, what are the errors? Now, for example, when we run the clinical trial sites, we are very kind of smart people, very neat and tidy, proactive people. So we print our consent forms, our protocols, our CRFs, and then we file nicely, we use them. So what happened once one of the sites, we in Australia, so the protocol change was done. And one thing you have to know, in each changes, you should inform our ethics committee. We need to get the ethics approval. So we submitted ethics approval. An email came that day morning. Ethics approval said, yes, we granted approval for this change. From that minute, that time onward, the new protocol is in place. So we can't anymore use the previous protocol, previous CRFs. But unfortunately, our site members, they didn't check the email. They recruited 2 patients on that day with the previous protocol, right? Previous protocol, right? So that is a matter of couple of hours. Email came this morning, and the same day afternoon, they recruited the patient with a previous consent form based on the previous protocol. That is the protocol deviation.
Yeah.
So
Can I just give a summary to make sure that everyone follows?
okay.
Jadi kalau tadi jawaban siapa? Ya, kan harus reconsent ya. Tapi kalau dari penjelasannya Pak Syukri, kalau pasien-pasien yang sudah direkrut sebelumnya, itu nggak perlu reconsent, tapi protokol yang baru akan berlaku untuk pasien-pasien yang akan direkrut ke depannya. Tapi salah satu error yang bisa terjadi adalah bisa jadi timnya itu tidak cepat terinfo tentang perubahan protokol. Jadi sebagai contoh tadi ada protokol yang sudah disetujui tapi melalui email, tapi timnya tidak buka email. Jadi ketika buka email ternyata mereka sudah nambah 2 pasien baru. So what did you do with those 2 patients?
Yeah, that is a big protocol deviation. So in that case, you are correct. So we had to go back because we used the wrong protocol version of that consent form to get the consent. So we need to go back to the patient. This is a standard procedure for that. We had to explain to the patient, and then we reconsent the patient with a new protocol, number 1. Number 2, we have to submit our protocol deviation explanation to the FDA, trial committee, our ethics committee. So lots of documentation required because we did a mistake. We used the wrong protocol, wrong patient information sheet and consent form, but it's a very simple thing. It's very, but it is very important. So whoever works or going to work in the clinical trials will be very vigilant about these small things, just checking the emails. That may end up, a lot of inquiries, a lot of documentation, a lot of explanations.
Ya, jadi meskipun hanya 2 orang yang direkrut dengan protokol yang lama, tapi mereka harus reconsent the patient. Pasiennya dijelaskan lagi, diminta konsen lagi karena prosedurnya harusnya sudah berganti. Kemudian mereka juga harus menjelaskan ke komite etik kenapa 2 orang ini direkrut dengan cara lama. Jadi simple mistake tapi implikasinya cukup rumit.
And other important thing is like once this protocol is changed, so we need to go through whatever the changes and we make a documents, simplified documents. These are the changes going to be implemented in the future patients. So one thing happened. So there was a protocol change from one version to the other. In that, one of the changes was screening criteria. So there was normally when we screen the latent TB patients or TB infection we do IGRA test or IGRA test or quantiferon gold test or TST. That is what you call TST. What do you call?
Mantoux test.
Yeah, so TST we do. So initially the TST measurement was 10 millimeter. If the TST is 10 and above, that patient is eligible to be treated. So then what happened? The patient came with the TST 10. It was positive. So a couple of days back, the protocol change was happened. So that says the TST should be now 15 and above. It's not anymore 10. But a lot of changes, as a human, we overlook that particular criteria and we recruit the patient based on the 10, right? Then patient was in the trial. And once we recruit the patient, we keep them for 2 years follow-up. And then patient was there, all the things was done. And then patient complete the treatment, follow-up was completed. So based on 10. But until patient completed all the follow-up over 2 years, we didn't have any issues. We didn't even think of that. The screen was incorrect. So what happened? I will talk about monitoring later, but one of the monitoring we said at the end, like recently, identify issue, right? Then the other mistake. Now, if this patient was able, you wrote the ineligible patient. But we know if TST is 10, then there are two criteria. TST should, and then if we say IGRA positive, then we can argue with them, IGRA positive, so TST 10 doesn't matter, invalid. So we are okay. We recruit a correct patient because later, after 2 years, we still did the IGRA positive. Then we we did the correct, though it was doing. So now my question is, what is the big problem we did? What is the big thing, wrong thing we did? Can you say we did a big mistake? What was that?
Ada yang bisa menjawab? Jadi awalnya inclusion kriterianya adalah TST-nya lebih dari 10, tapi kemudian mereka mengubah protokol menjadi lebih dari 15. Tapi kemudian mereka menambah kriteria lainnya, IGRA positif. Nah, kemudian mereka tetap melakukan inklusi dengan kriteria itu.
So I want to emphasize that IGRA test was done after 2 years, after completion of the follow-up.
Ya, IGRA-nya baru dilakukan setelah selesai follow-up. Jadi supaya mengkompensasi kriteria yang 15 tadi. Ada yang mau menjawab kira-kira apa yang bisa terjadi kalau kita melonggarkan kriteria inklusi seperti itu atau memodifikasi?
Sorry? Yeah. Yeah.
Can you use your microphone?
I think we violate the first protocol just to expect something that unsure in the future, like IGRA positive.
Yeah.
IGRA can be positive or not in 2 years, but during the protocol, we violate the agreed protocol.
Yeah, so we violated. Yeah, so and by doing IGRA, so what the big mistake we did. So one is initially violated the protocol, recruiting the wrong patient, which is not positive patient. As per definition, we recruited wrong patient as per definition, change definition. So then to correct that the wrong mistake, we did a bigger mistake. So what was the bigger mistake we did?
Kira-kira apa yang bisa terjadi dengan
Perhaps it's relapse TB.
No, this is all latent TB patients, not the TB patients. Yeah, so it's not a relapse TB, but in a following the protocol, doing one thing and trying to correct that thing, we did a bigger wrong mistake. So can you think of, so that is good learning point I want to emphasize here.
Halo, yang dari Pulmo?
All right, so without taking a lot of time, so the number one, we did a big mistake recruiting an ineligible patient. If IGRA, according to new protocol, IGRA is 10, then that patient is ineligible. So we wasted our money, we recruited wrong patient. Then we had to deal with that issue and submit all, as I said, all the documentation, FDA, this and that. There's a lot of administrative work. But we were like smartly thinking, and to correct that one, we said, definitely it should be like a positive. Then we called the patient after 2 years, And then we asked the patient to do the IGRA. It was positive. We were happy. We are informing them. Oh, we did the IGRA, and so patient is positive. It means throughout the study is positive. So we did not exclude the patient as an ineligible, but it was a big mistake. Why? According to protocol, we can follow up a patient for 2 years only. After 2 years, even 1 day after, you can't talk to the patient. As a trialist, we are consulting with the patient. Exactly, we will be following them up for 2 years. After 2 years, no communication. You can't call the patient. You can't do any test. You can't do any procedures. You can't do any follow-up after end of the study period. But to correct our mistake, we did a bigger mistake to contacting the patients and ask the patient to do the IGRA test. Then that was a bigger mistake we did, and we learned bigger lesson from that. So yeah, so what take-home message from here? Whatever the protocol says, end of the treatment, end of the follow-up, that's it, that dot. From that dot, you can't go beyond. So even you need No. Even if you need to justify something, no. So patient cannot be contacted after the certain agreed period. That is a big mistake. Now we are dealing the second issue, explaining why we did that mistake. So whatever I have spoken is a suboptimal allocation or wrong allocation. So that is screening, consenting, all these mistakes. If you do these mistakes, we'll be allocating wrong patients. If you allocate the wrong patient, what will happen? The validity of the trial may not be there, right? And then reporting. So sometimes, reporting also important. Each and every time when we are reporting, we need to do proper assessment, whatever the symptoms, signs, and dose records, and whatever the things or blood tests, we have to report correctly as much as no compromise should be done in the reporting. But what are the errors can happen in reporting and how we can minimize that errors? Reporting errors are not a big mistakes that can be correcting mistake, but not overcome things.
Oke, teman-teman paham pertanyaannya? Jadi untuk reporting, is this reporting at the recruitment?
When we recruit the patient,
Yeah.
then
At
patient
the
should be assessed
recruitment.
periodically and then documented.
So at the recruitment phase, right?
Recruitment and then following up. Like every time when you check the patient, you need to measure certain symptoms and then measure certain things, certain lab tests, and then this should be recorded or reported correctly.
Yeah.
So what are the mistakes can happen in that situation and how we can overcome?
Oke, jadi pertanyaannya dalam clinical trial itu ketika kita melakukan rekrutmen pasien dan follow up, kan banyak pemeriksaan-pemeriksaan yang dilakukan dan itu pasti dicatat kan. Nah, dalam dokumentasi dan pelaporannya, kesalahan apa atau error apa yang bisa terjadi dan implikasinya apa? Misalnya harusnya dicatat di form ini, tetapi kemudian ada perawat yang mungkin tidak lengkap atau keliru form atau lupakan, jadi dokumentasinya tidak lengkap. Nah, kira-kira apa yang akan terjadi? Konteks penelitian ya, tapi mungkin mirip-mirip dengan konteks clinical practice juga ya, ketika teman-teman di praktek di rumah sakit, kemudian ada pencatatan dan pelaporan yang nggak sesuai dengan kondisi yang sebenarnya, kira-kira apa yang bisa terjadi?
We will misinterpret the symptoms or side effects if we are not following or input the data correctly, like the symptoms during the treatments or side effects.
Yeah. So human mistake can happen, like when you are screening symptoms or interpreting the lab data or checking, for example, blood pressure or body temperature or some kind of objective measures. When we are taking all these vital signs or whatever, when we are measuring, we can make mistakes. That mistake can cause wrong reporting. That can cause some other consequences. So wrong reporting can cause some wrong decision. So that is problem. Then how we can overcome these things now? So the human errors, while we screening, while we doing all these data collection and reporting, how we can minimize these errors? So there's a way now to minimize these errors.
To others that involved during the trials.
Yeah. So whatever the measures we needed should be very well informed everyone in the team. That is one thing. How we can minimize that? Even human errors. As a human, when we work, our mental status may be not the same all the time. We be under pressure. We were tired. Maybe may have some other issues. So then we may not consciously looking at the patients or consciously interpreting the data. That can happen. So to minimize those things, we can't 100% get rid of these, but to minimize these, what sort of thing we could do?
Untuk mengurangi error-error seperti ini, apapun alasannya, kira-kira apa yang bisa dilakukan? Tuh. Wait until the microphone is coming.
Maybe we doing like a double checking.
Yeah. So double checking, and second thing. Well done. Thank you.
Thank you very much.
So yeah, so one thing is if we don't have any digital technology or AI method to assess these things, we can still do double checking. So one person reporting, other person is correcting. If we have, like, for example, one of the screening criteria is checking the chest X-ray. So chest X-ray is very carefully checked before recruiting the patients. So if you misinterpret chest X-ray, going to be a disaster. You end up recruiting wrong person. So then we can introduce now AI models are there. Very short time, AI can interpret the chest X-rays rather than human. And accuracy is much higher than the human interpretation. Also, devices like a smartwatch or a smart ring or something we can give to the patient. The patient can quickly wear that can, get the blood pressure and all those other parameters to our system straight away link, so that human interaction will be minimum. So we can minimize the human involvement by introducing a smart way of collecting the data. That is one thing. But second thing, if you don't have anything, there should be a process of double checking. So one person get the things, one person verify, and then enter. Again, paper, protocol variation, and then, right. So blinding also an issue, right? So now we say our trial actually is not a blinded trial, but in most of the clinical trials are either single blinded, double blinded, or triple blinded. So what are the problem may occur in terms of revealing or by mistake revealing the blindness? So how it can happen, how unblind can happen, and then what are the consequences of if unblinding happening, and how to resolve these blinding issues if revealed. Blinding is important part of the trial, but sometimes it is being revealed by so many reasons. What are the things that cause revealing the blindness? And then if revealed, what are the consequences of that? And then how to fix that issue?
Oke, kita udah belajar tentang blinding ya, jadi teman-teman pasti ingat blinding itu apa. Nah, pertanyaannya Pak Syukri, kalau misalnya blinding itu di tengah-tengah jalan ternyata kemudian nggak sengaja terbuka, ada yang tahu nih statusnya apa, dia kontrol atau intervention. Apa kira-kira yang akan menjadi konsekuensinya? Oh, wait.
Yeah, maybe the participant will be dropped out because they feel they not take the medicine that they must be have, and then they don't want to continue the RCT. Yeah.
Thank you so much. So maybe one of the consequence may be a dropout. So my question is now, what are the situations unblinding or reveal of blinding happens?
I think the side effects of the drugs.
Okay, that is naturally happening. Side effects, very good.
Yeah.
So that in that situation, we need to no choice. We need to reveal and then treat the patient accordingly. If we call it AE or serious adverse event happens, then can't keep the patient blinded anymore. Some other measures, what sort of reveal or not blinding happening? It can be as a part of the procedure or beyond that.
Ya, kira-kira selain efek samping, kondisi apa yang bisa menyebabkan unblinding? Jadi blindingnya secara tidak intentionally terbuka. Selain side effects tadi. Kira-kira apa hal-hal yang bisa menyebabkan pasien tahu statusnya? Bahwa dia sebenarnya ada di intervention atau control group. Ya? Yeah, unintentionally informed by the health care workers.
Yeah, that is very common mistake done by the healthcare workers. Those who knows about the randomization or which allocation, they might reveal this one. That is a big mistake happening. And also, what happens, like, not this trial, but we had another trial. We recruited 15,000 patients. That is called pralidoxime trial. It's a like antidote, pralidoxime antidote for organophosphorus poisoning. So it's a liquid IV medication we give to the patient after double blinded, like randomized. Then patient used to receive either pralidoxime IV with a bolus and the continuous one, and then versus placebo, identical placebo. But our research team were very smart. After a couple of patients recruited, they know after like it's identical if you look at by like just visually, but they could easily find like which is drug, which is placebo. Then that blinding process was not appropriate. So if it is unblinded, what is the problem? And also with our trial here in the asteroid trial now, it is not blinded, but only one person is blinded who is making like, AE decision, like adverse event, serious adverse decision makers, always blinded. So they should not know what is the treatment. Based on that, they can say whether it's adverse event or serious adverse event, and accordingly we can stop the treatment. So that in our trial, so what we normally make mistakes. If we have an adverse event or serious adverse events, we need to report to them. By mistake, we write, okay, this patient allocated this. I mean, as a flow, we write. I mean, we have to write a whole history. So it's a patient recruited this date, this was done, and then allocated this treatment and found these signs and symptoms, and so something like that. Then they receive that report, and then it's clearly say what allocation that is unintentional or intentional violation of the bias. So if these thing happens, what is the consequences? Like if is revealing, like for example, earliest example was, clinicians or the trial team, they slowly, gradually, they come to know when patient is receiving this is placebo, this is treatment. So, but they're supposed to be blinded. So in this situation, what are the mistakes or what are the errors can happen if they come to know? If the patient come to know, if the trial team, clinicians or trial team come to know this is, or they were opened without blinding, what is the issue with that? What is the consequences?
Oke, kalau blindingnya gagal karena meskipun tidak sengaja, klinisinya jadi tahu, kemudian pasiennya tahu tentang status pasien, kira-kira apa yang akan terjadi? Ya? Ya? Kenapa? Sorry? Oh, it can cause failure or
it's sort of bias, as he said.
Yeah.
Like for example, we always believe our intervention is good.
Yeah.
And we always think this is effective. So we care more. We like look for better outcome. If we know, okay, this patient is receiving our intervention, then we look at seriously look for the good things. And then we may not look for the same thing with the control patient if we reveal. But if we don't know, then we are equally treating everyone, whatever the data we collecting equally. But we are human. We always think like we are smart. We do correct things. Whatever our medication, new medication, good. So we look for good things, and we forget about look for the good thing for other group. So that is a big issue. This is a data bias. So to avoid that one, we blinding. But if blinding reveal, this issue will be there, right? So overcome this unblinding or revealing, what we could do, how we can overcome this kind of mistakes, mistakes or intentional, how we can overcome.
Kira-kira bagaimana mengatasi apa namanya supaya blinding jangan bocor? Ada yang punya ide biar nggak saling membocorkan? Komitmen from the clinic. Oh ya.
In the beginning of research, almost the people that
involved in the study,
assigned the commitment to protocol from the start until the finish to
So
make
kind of
the
a non-disclosure agreement.
Yeah, so we should have some pledge or agreement. So we should not violate the protocol. We should not go and revealing or understanding what this, what that, all those things. Any other options? So this is all like, this is not written. These are like practical things we encounter, we solve, and we learn. So this, I feel is important. And we may not able to find this one in the textbook. So this we have to encounter, we have to face, and we have to resolve. So maybe answers may not be like black and white. So based on the situation, we may have some different approach. So how to overcome or how to minimize unblinding or revealing the allocation.
Mungkin ada lagi usulan bagaimana biar mengurangi unblinding?
Change the stuff.
Change the stuff. Dipecat. Yeah, standardize the procedure. Somebody answer with standardize the procedure, but we already do that.
Yeah, standardize the protocol procedures.
Procedure.
Yep. Yep. So yeah, as I said, like there's no any black and white.
Sorry.
To treat analysis, ya, jadi walaupun dia sudah tahu bukan maksud dapat placebo, tapi pakai intention to treat analysis.
Use the intention to treat analysis. So even though they already reveal the status, they can still treat the patient according to the planned allocation.
Again, sorry.
Intention to treat analysis.
Intention to treat analysis, yes. And then what was the question?
No, she was answering your question.
Okay.
What to do with unblinding, and she said intention to treat analysis to overcome the unblinding.
Yeah.
But the allocation doesn't change, right?
I mean, allocation won't be changed. It remains same.
Can you get closer?
The allocation won't be changed. It will remain same. But the problem is like whatever the data based on the allocation received or collected from the patient may not be reliable because the human make some kind of severe intention to get the correct data for intervention arm and not the same with the control arm. So reliability of the data is poor. And then in that case, like if this happens, there's nothing we can do unless we have to acknowledge the mistake. So, and then quality, reliability of the outcome will not be there. And then also remember, clinical trials are not cheap, millions of dollars. And then if small mistake, if causing the harm to the trial, and then after 10 years, after 5 years of conducting the trial, whatever the outcome may be strong if you do this silly small mistake. So it's not a cheap and it's not like a lot of effort, a lot of time, but we have to be very, very careful. Right, next slide, please. So we have discussed this one, randomization and reporting and then blinding. So next, please. And then we also discussed this one. Just keep it that the previous one. Okay. So overcome, the errors, reporting errors. We can one of the way we can do is digitalization and also a smart way of data collection, and then supply of services, and then authorize the triggers, manage the medication keys based on the schedule, keeping the assignments. So yeah, these are the ways of minimize the reporting system. Next one, please. So when we are randomizing, we can use different types of randomization process. So now we normally in the clinical trials, nowadays we don't do any manual randomization, but we computerized stratified based on age, gender, and whatever the criteria are relevant. We stratify or we block the participant, one block, and the block is a block randomization, or we also do the adaptive randomization based on learning. We change the randomization criteria and keep adaptation process. And then cluster randomization, we randomize not individual as a clusters, maybe hospitals, one hospital, one group, the other cluster as other hospital, or one area versus other area. So we can do different way of randomization in order to maintain the random sample that minimize the bias. Next one, please. So we had discussed this one, blinding and blinding issues. Now, I said our trial is not blinded. I mean, which I am giving as an example, a steroid trial for TB prevention. But according to these four criteria, four types of blinding, this asteroid trial, which I've been giving examples, can you tell me which sort of blinding is there in our trial? But I said no blinding, but there's a small portion of the trial being blinded. So according to these four, which sort of blinding we have implemented in our asteroid trial, which is TB prevention trial? Out of 1, 2, 3, 4, which one you think in our study we implemented?
The TB trial?
Yeah. But I clearly said it was a not randomized, blinded trial, but some blinding is there, but what's that type, the name of that blinding out of these four?
Yang mana yang diterapkan untuk TB trialnya Pak Syukri ini? Single blind, double blind, triple blind, atau operational masking? Jadi dia tadi cerita bahwa ada dilakukan blinding tapi tidak secara sistematis ya. Ada 4 jenis.
No.
Operational
I said clearly it's not a blinded trial, so open trial, but there's some masking, some blinding is there. I'm asking according to out of these four, which blinding is
The
there?
group say operational masking.
Number 4. All right. So we put this operational masking, not the blinding of this one. So again, out of curiosity, what is triple blinding? Anybody? What is triple blinding? Who are blinded in triple blind trials? Who are the 3 parties should be blinded? Number 1, participant. Number 2, staff, clinical trial staff. Participant, trial staff. Third one, sorry? Data analyst. Very good. So I don't have much. So who? Huh?
It's there on your slide.
What?
The answer.
Okay. Okay. Right. Next one, please. So how to maintain the blinding? These are the few options we have, like, unblinded pharmacies, placebo consistency. So we have to mesh the placebo 100%. When we are doing the placebo blinded trial, it's very tricky, and very hard to maintain, like, drug color, drug taste, appearance, fragrance, all should be matched. Otherwise, it's not anymore blinded. So we have to try our level best. And then ECOA integration captures patient data directly, remove the investigators and all those things. So these are how to maintain the blinding. We have discussed this one. Next, please. Next, please. So, okay, what are the risks when we unblinding? Accidental unblinding can happen, as I said, by sending the email to the sponsor saying, we randomize this patient to this, then accidental. And then emergency break, like as you said, if it is severe side effects or adverse event, we can unblind. That is okay, we should do. And then later leakage can happen. And then sensory unblinding, like high severity demand the conduct of the rigorous placebo matches, something like that. So these are the unblinding risks we may face in the clinical trials. Next, please. So whatever things happen, clinical trials, we have to be very transparent. So number one, we should try to do the clinical trials as much as 100% following the protocol. But if any mistake happen as a human, we should never mask or hide. That should be reported. Sometimes it's painful because always saying we did a mistake, but doesn't matter. As far as we acknowledge, that is good for the trial. If you hide the mistake, if we are not reporting the mistake, that may cause the serious impact on the outcome of the trial. So our main intention is to evaluate a product, a medication or an intervention, whether it's effective or not. To see that one, whatever the process, because as a human, nobody can do 100% perfect trial without any mistakes. So my advice, when you are conducting any trials, any studies, mistake may happen. It can be smaller mistake or bigger mistake, doesn't matter. You have to accept it. You have to report it. That is very, very important. And then there are reporting system, for example, any AE, adverse event. Okay, so this is very technical again. Just asking, anybody has any experience involved in the clinical trials in any setting? Anybody has involved as any level of clinical trials, like a trial assistant, trial coordinator, trial manager, any sort of thing? All right, no problem. So just quick things. If an adverse event happened due to trial patient facing an adverse event, so number one, to whom we should report? Number two, within how many days should be reported? If an adverse event happened to a trial patient, how soon? That adverse events are well defined in the protocol. So based on the protocol definition, if an adverse event happened, number one, to whom we should report? Number two, how soon, the minimum, the deadline, we should report this adverse event?
Can you repeat your question?
If an adverse event happens while patient is in the trial, number one, to whom it should be reported, and then when should be reported, or within how many days or hours should be reported?
Oke, meskipun belum pernah ada yang terlibat langsung dalam clinical trial, tapi misalnya ada Anda melakukan clinical trial terus ada adverse event terjadi, ke mana harus dilaporkan, ke siapa, dan kapan harus dilaporkan? Ada yang mungkin pernah baca di protokol paper atau apa? Kan ada side effects monitoring kan? kapan itu harus dilaporkan? Menunggu apa atau harus dalam waktu berapa lama? Ya. Oh, Dokter Tantri.
Okay, I'll try to answer it, but I never involved in clinical trials before, but I think that they have to mention like instantly and to report to the one either like contact person or something, because at first events began divided to like minimal and or even like really I don't know, parah.
Severe?
Yeah, severe. So yeah, before they get into severe, we have already need to know about the mild one.
Yeah.
Thank
Okay.
you.
So I'm just going to give you a brief about how to deal with adverse events. So first, as far as if you see an adverse event with a patient on the trial, number one, clinician should see the patient immediately and then make some clinical judgment. If needed, no need to do anything but stop the treatment and then try to solve the problem of the patient, right? That is first thing should be done. Patient care should be prioritized. So don't care about the trial, stop the trial if it's adverse event, and then if like a real adverse event, then clinician should see the patient and then start looking after the patient accordingly. Then my question was, to whom it should be reported? There are few people should be reported. One is our ethics committee. And then number two is a sponsor. So a sponsor should be reported. An ethics committee or FDA, or HREC or whatever you call, the ethics regulators should be reported. And then when should be reported? It is kind of standard. If it is an AE, adverse event, it should be reported within 5 days. So AE should be reported within 5 days, all right? And then another category is SAE, serious adverse event. So if a serious adverse event happens, within 48 hours should be reported to HREC or ethics, also sponsor, right? So again, serious adverse event can be defined in the protocol clearly according to the nature of the trial. So serious adverse events within 2 days, adverse event within 5 days should be reported. If you are not reporting, again, protocol deviation, then again, lot of paperwork, right? So must be reported. And then accordingly they can, but first thing is, before reporting, you have to look at the patient, care the patient, treat the patient, advise the patient, and then immediately you need to report. So different way of reporting are there. So maybe electronic reporting or manual reporting. But some ethics committee, they say you don't need to report immediately if it is AE. If it is defined clearly, and then you can report as an annual report, that's fine. But most of the time, you need to report within 5 days. But sponsors, yes, must be reported within 5 days. And then transparent, again, you admit any mistake happened, anything you should admit, acknowledge. No need to worry about telling the truth about the patients or what mistake, what wrong thing happened. That is fine. You need to report whatever happened, right? Next slide, please. So in the clinical trial, there are we call it consort report. There's a way of reporting, even like after analyzing, after doing the clinical trials, we need to report according to the consort guidelines. So consort 2026 is there, and then according to that, all the steps should be followed. This is more on A to Z report, not AU SAE reporting, but A to Z should be reported to sponsors and relevant bodies once it's done. Next, please. So these are the things we have discussed already. Randomization, like traditional operation way, and then decentralized operation ways, the blindings, and then the newer method and reporting, localized method, and Then real-time multi-source digital ingestions are there. So, I mean, what are the things we have reported? This is a way of discuss. These are the things, and then oversight. All these things are there. All right. So one more thing I think I haven't included, but I will mention here. Now we, as a local team, we do everything as per protocol, but there are someone should be monitored all the activities. So we call them like trial monitors. Trial monitors can be independent body, which not either from us or from ethics or from a sponsor. It's a total independent body will come to the site and then monitor every activities, every documentation they check, right? So should be done. So what is the frequency of monitoring? So that is also important. So when clinical trial is start, after second patient is recruited to the trial, there should be independent monitoring early enough to check we are doing the correct thing. So that is must. So after second patient is recruited, the monitor should come. So a sponsor should organize the monitor. They should come and check everything. After that, every 6 months, at least every 6 months, monitoring should be happen. That should be done by mostly independent person or sponsor, right? Next one, please. So these already discussed, scientific balance and eliminating the bias and transparent recording, and then competitive edges like, yeah, this is already discussed. Next one. All right. So one of the important thing with the trials is a follow-up. So so sometimes, if we lose the patient after certain months or certain period, it's a very big loss for us because we put a lot of effort, a lot of money, recruit the patients, and then after some time we lost the patient. So that is big issue. So my question is now, that some trial, for example, this asteroid trial, which I was giving examples, this trial is, 24 months follow-up period. Like we have to follow them up over 24 months. It's a big follow-up period. So then chances of getting like loss to follow up is high. So as a researchers, what your suggestion, how we can overcome loss to follow up after recruiting? How to overcome loss to follow up?
Ya, jadi salah satu kesulitan kita setelah pasien direkrut kan loss to follow up ya. Teman-teman sudah tahu semua apa itu loss to follow up. Kira-kira apa yang bisa dilakukan untuk meminimalisir loss to follow up supaya pasiennya nggak hilang dan masih bisa di track? Kalau pasiennya rutin kontrol bisa ya, tapi kalau pasien yang sudah nggak bisa di track gimana kira-kira? Ya, the one in the corner. Oh, nggak tahu mas.
Opportunity. My opinion, there's two things to do to overcome the loss of participant. The first is offering the incentive. Sometimes the incentive can make the participant, the patient, come to our clinic, come to our research. And the second, make flexible time visit so the patient can come to research according to their time. So with the flexible time, they can relax to follow our research. There's two things.
Yeah, excellent, excellent, very well.
Finally, after almost 2 hours.
Yeah, so it's a very important points to consider. Like we do research, we are committed for the research, but patients are not like that. So they have their work, They have their own routine, their family and all those things. So we have to be flexible. We can't say, we are researchers, you should come according to our time. No, we have to work according to the patient's time. So we have to be very flexible. Number two, when they come to clinic or our research activities, they may lose their working hours. They may ended up like having transport cost and all those things. So we should compensate that kind of loss they encounter by giving some incentives. So of course, clinical trials are like well-funded trials. We can give sufficient compensation or incentives to the patient to overcome their income or some issues with coming to follow up. So by that way, patient will be confident that, okay, even if I go, I won't lose because I'm getting some incentives. And also, if we are flexible, then yeah, patient will be happy. And the third thing is, in addition to that, we can also explain to the patient the importance of completing the trial. So that way, if patient can understand the important, like, if you can explain clearly, this is very important to finish the trial, then they will, with understanding, they will be very happily contributing. So what strategy we use is, all in addition to, as he mentioned, that incentives and then adjusting our time. Sometimes we do follow-up course at night, early in the morning, according to patient flow. So that is okay. Also, we convince the patient saying that, after completion of this treatment, if the treatment is, effective, that is your contribution. By your contribution, we are developing a new medication to treat thousands or millions of people or patients in the future. That is a big contribution you are doing to the society by just participating in this study. By that way, we emphasize the importance of being an active participant in the study. So that is one way we can tell them the importance, but we can't force them. We should not force them. You must come, otherwise you will be in trouble, or you will not seen by a doctor, this and that. We can't force them. This is again voluntary participation, right? Another thing, loss to follow-up is a big issue, but because of overcome that issue, we can't violate the protocol. So how the protocol can be violated to overcome the loss to follow-up?
You are asking how or when?
No, how?
So
how lost how protocol violation can be happen, protocol deviation or violation can happen to overcome loss to follow-up. So we understand loss to follow-up is a big issue.
Yeah.
To overcome, we do something that cause protocol deviation. So how it happens? So my question is, what we do, what sort of things we do that cause protocol deviation to overcome?
Allowed to do or
not allowed, but deviation. We are doing the wrong thing to overcome loss to follow-up or minimize the loss to follow-up.
I hope I get your question correctly.
Do you understand? Or not?
Yes, jadi kan tadi di depan dibilang protokol deviation nggak boleh ya, tapi kadang-kadang kemudian kita mengubah protokol supaya loss to follow up diminimalisir. Apa saja yang biasanya kita lakukan untuk mengubah protokol itu? Yang harusnya nggak boleh. Misalnya tadi masalah insentif, kemudian dibesar-besarin biar bertambah. Itu kan protokol deviation sebenarnya kan? Atau awalnya tidak ada insentif, kemudian kita supaya respondennya tertarik, kemudian dijadikan ada insentif, itu juga sudah perubahan protokol. Nah, selain itu apa lagi? So you're asking what we usually do, or researchers
protocol
do
deviation to overcome loss to follow.
I give an example of in the former protocol we don't give any incentive, but then we give incentives to distract patients. Is that one example?
Yeah, not example. I'm using something like that example. We do the things we do is a protocol deviation. But we think by doing that one, we can protect the people from loss to follow-up. But what that thing we do? That's my question. Most of the time we don't realize there is a mistake, but it is a mistake, big mistake we do. We believe our trial is important. So we do that thing to keep the patients in, but that is protocol deviation. Then no point of doing because already we are deviating or violating the protocol.
Oke, jadi hal yang kita lakukan untuk mengurangi loss to follow up, tapi sebenarnya itu adalah kesalahan karena itu menyalahi protokol. Kira-kira apa? Bahkan menerjemahkan pertanyaannya pun sulit sekali.
So next time you won't invite me for guest lectures.
No, I got your question now. It's just,
No, I mean because a lot of questions, so you won't invite me.
Ada yang mungkin kepikiran?
Violate in this case.
I mean, I'm asking. I mean, protocol says you do this. You should not do this. So we have to follow the protocol. If you not following the protocol, it means deviation or violation.
Yeah.
So to keep the patient in the trial, we often do protocol deviation or protocol violation. I'm asking what that simple thing we do.
Yeah, you're asking for a specific term for that.
Yeah, specific term or explanation what we do. Yeah.
Perhaps contacting other persons that closely related to the subject.
Yeah, so exactly, but you partially answered. Yeah, that's correct. So what happened, according to protocol, we have clearly defined a patient can be contacted maybe 3 times or 4 times. That is max, right? So beyond that, we can't contact the patient for a specific follow-up. So we can remind them, number 1, number 2, number 3. It can be different way of communication, maybe call, email, or text message or something. According to the protocol, we need to contact the patient. So if the protocol says 3 times, there's no 4 times or no 5 times, only 3 times. But we, out of, more interest, to keep the patient in this one, you keep calling them, keep bothering them. I can say bother them or keep pushing them. That is protocol deviation, protocol violation. We can't do that. So if 3 times, you can do like today you call, ask the patient to come, didn't come. Maybe you can think he's busy or she is busy. You can call different time, different days. That is fine. Second time. And then if protocol says maximum 3 times, that is all. No more than 3 times. If protocol says 4 times, that is max, not more than 4 times. If you are trying to contact the patients beyond that limit, that is protocol deviation, then that is an issue, right? So it is important, but still following the protocol is very important than loss to follow-up. So you can't compromise one for the other. Do you get my point? Okay. Right, it's a very common mistake we all do because we are very keen to have our patients record available on time, everything. So we tend to call many times as many, then that is protocol deviation. That is not correct in terms of clinical trial. Next slide, please. Right. So to overcome or optimizing the clinical trial through the risk-based monitoring. So once monitoring take place, there are so many problems will be raised. Like, you did that. So monitoring is like a kind of intense, so you might have gone through the accreditation process, something like that. They dig each and every single thing, every single document, every single thing. They check, and then they come a lot of issues, lot of queries, lot of things to answer. So to overcome these things, what happen. So I'm not telling in the clinical trial, of course we make, but any mistake happens, then one important thing we should learn, that mistake should not be repeated. That the mistake can happen. If any mistake happens, that should not be repeated. So then to overcome, not to repeat the issue, we call it CAPA procedures. Corrective action plan. The corrective action plan should be documented. So once some issue is happened, then we have to acknowledge, we need to describe what the issue, then action plan. What was the corrective action plan we have done? What is the implication of that action plan? That should be implemented all the sites. Even if it is happening or one mistake in one site, if you have 4 or 5 sites, all the sites should be CAPA document, corrective action plan should be prepared and then distributed to all the site, so that in the future that mistake should not happen, right? So if repeated, that is going to be a issue. But one issue, that's fine. Based on that issue, we have to have proper reporting that we call CAPA reporting, corrective action plan. That report should be submitted to the sponsors and ethics committee. Then we should follow that CAPA procedures from that point onward. So CAPA means corrective, preventive action plan. And then the other problem is, the CROs or monitors, when they come to the sites, then there should be always not good communication, because they are coming to look for the mistakes. So trial team is not happy to be, victim of the mistakes. So that communication may not be appropriate or pleasant, but not that the case. As a researchers, as a clinicians, or as a trialists, we should understand this is a trial. This is not a end of the world thing. So we should not make take it as a personal offensive things, or should not defend. So whatever the CRO or monitor says, we need to acknowledge, we need to explain, we need to take corrective action. So because of the monitoring, we sit and monitor, find a lot of mistake, it should not be offended or something like that. Next, please. So, all these things, if you follow all the data management plan and consenting and all the standards way, and then there should be data integrity will be there, advanced global human health outcome will be there, and then we can report accordingly. Next, please. So if you want to more resources or references about clinical trials, conduct of clinical, these are some resources available. You can read or you can understand, you can even search for. Next, please. That's all. Sorry. So this is more on operational things, what we do, clinical trials, how we do. Then if you have any question related to issues related to conducting the clinical trials, I'm very happy to answer.
Thank you very much. Please give a big applause to our speaker this morning. I just realized that not only the material, not only the presentation is real what clinical trial about, but also the real guest lecture. Because in my experience, this is the first time I saw that many of feedbacks and many of discussion during the presentations. And I could say he is very good lecturer. Please give an applause for him. Yeah. Thank you so much, Dr. Sukri. So during the lectures these mornings, Dr. Sukri invited us for discussion and asking many questions. And now is our turn to have an ask question to Dr. Sukri. If you have any question, just raise your hand or either on site or online Zoom meeting. Just open your mic and open your camera, and you might ask the questions. And please tell me your initial or name before asking questions. So we are welcoming all of you to have a question, please. At side, one question. Thank you.
Hello, good morning. My name is Dr. Tantri, so I'm a friend of Dr. Nila. I have several questions actually because it's quite interesting, but we're not really know about clinical trials. So, first one, you mentioned about AI or digital tools that we can use in clinical trials, and it's quite helpful also. But to what extent that it appropriate to use or to rely on AI in a research process, and do we have like a boundaries or limitation how far we can use it? And the second, because you also about talk about the loss to follow up, but we can in the clinical trials we do also find something about the death during the follow up is either from the disease itself or probably any other other disease. How you mention about that during the follow up, is it we report as one of the causalities or severe, or I don't know, it's the same with loss to follow up? Thank you.
Thank you so much for the questions. You might give your response.
Yeah, thank you so much. Thank you so much for raising these important two issues with us. Number one, how extent we can use the AI. So as far as the AI model is validated, appropriate, I mean, you can't just use any sort of AI model, but for example, I specify things. For example, if you want to interpret the chest x-rays, if you have a lot of patients, the human errors may happen. So we have established AI model to use. So those validated, established models we can use to interpret the data. Number two, now we have like smart devices like a watch, smartwatch or smart ring and all those things to check the vital parameters, for example, blood pressure or heart rate and or saturation level and all those things. That is more accurate than checking with this scope or something. Those devices be used. So if it is approval or validated tools, no. If it is validated, if appropriate, is no harm. The second question is very, very important, death. Yeah, death in all clinical trial, it doesn't matter, it's whatever the trial, death is immediately reported as a serious adverse event, number one. Whatever death happened, it can be due to the trial medication or maybe some other comorbidities. That's fine. Whatever cause of death doesn't matter, but it should be treated as a serious adverse event and should be reported within 24 hours, number one. Number two, this is fine. It's a loss to follow up. Or maybe some trials, death is an outcome. For example, some disease, with this medication, we can prevent the death. If death happens, this is an outcome. But if death is not an outcome, for example, I said another trial we did for poison patient, poison with organophosphorus poison patient. So if patient died, this is outcome. Patient survive, that is outcome. Death or survive with our medication. So that is, if it's an outcome, yes, death is an outcome, that's fine. If not, for example, normal other trials, which is not outcome, that's fine. We say due to death because it's unavoidable. So due to death, the patient lost to follow up. That is okay. And then whatever the data up to that point until patient dies, we can utilize those data in data analysis. I hope I answered the question. Yeah.
Is there any follow-up question from that explanation? That's enough. Yes, Dr. Sri has answered our question technically, theoretically, and I think it's a very comprehensive real story from the real activity of research in clinical trials. So if there's any question from the others, we welcome for the questions. There's
Okay. Assalamualaikum warahmatullahi wabarakatuh. Thank you for the opportunity to give a question for Dr. Shukri. So my English, I will try to deliver.
Sorry,
The first,
please repeat because we have a trouble with the mic.
sorry, my English is not really good, but I will try to deliver my question with English. So the first question is, so the previously slide you explained with us is there is 4 pillars, 4.2 about the about operational bias and clinical evidence. So I want to you to explain us about one of that opaque reporting. So um, how do we define the ideal level of data disclosures that and what strategy can we implement to balance the transparency of the data, and then we need to protect the patient safety, right, about the intellectual property. And then the second question about that we talk about the change of protocol, right? Uh, we want to know about outcome switchings. So because when we change the protocol, so we can have the outcome switching. So you can explain us about it.
Thank you.
Okay, thank you so much. Important questions again. Thank you for asking. So number one, you were asking about reporting, right? Or data disclosure. So okay. So I will explain to you the general procedures we or everyone should follow in terms of conducting the clinical trials. So there should be number one in the part of the protocol is data management procedures. There should be a big document clearly mention how data can be collected, how data can be revealed, how data can be like an anonymous or personal data can be open to whom, right? So that is very clear. And then the ethics committee is very keen on that. So if any data breaching, then we won't able to do the trial. So we had to protect the data. And then patient, okay, so in the practical thing, once we recruit the patient, all the patient documents should even does not have each and every document does not have patient name or any identifiable details. Only we use the patient ID. Whatever the identify, we remove even consent form and keep it locked, cupboard or something like that. So there's no any identifiable data available for anyone to reveal. Whatever the uh, I'm saying open up means like in the when I was discussing, I said if some adverse event happen, we need to reveal the things. Reveal the things in the sense like patient was allocated to which treatment, whether standard of care or whether active treatment or something like that, or how was the patient's blood pressure or blood report and all those things. Those are not the personal information, but patient disease-related information that access to all the clinicians, all the people relevant. But patient personal information will not be shared any circumstance to anyone unless it is like legally required for us to share. For example, a patient with a legal questioning from by court order or something, then that is something legally. Other than that, we never reveal any patient information to anybody else, including the sponsors. So that is one thing. Number two, you were asking about, what was the second one?
The protocol? The protocol outcome will be different when we...
Yeah, protocol changes, right. So whatever the changes we have in the protocol are more on, that may not impact the outcome. I can give you a lot of examples. So if outcome is changing, then that is not appropriate to make a change. That is different study, because our outcome cannot be changed over time, but process can be changed. So one example I told you, like initially we started recruiting patient TST results 10 mm. The later we changed to 15. So then whatever the outcome will be remain, then that criteria may not impact the outcome. And then another example we did, like initially we recruited only adult patient and we did the interim analysis and we found it was safe. Then we are including now pregnant mothers and children because it's proven by interim analysis safe. So whatever the outcome, again, no impact. And a few other changes we made to the protocol, such as like one of the inclusion criteria is patient should be migrated to from a high impact country or high income, so high TB incidence country to the low incident country, something like that. So that we change into number of the incident cases from 150 to 100. So those are the kind of things which never impact or which won't impact the outcome. So there's no need for any changes or any interpretation of the outcome. But if any major changes made in the protocol, which is making the outcome different or primary outcome different, then that is a kind of major change. That then whatever the patient recruited previous one, that is one cohort of patient, and then when the patient protocol change and the new outcome is this there, then this kind of different part of the trial. Then when we analyzing, then we have to analyze the first cohort towards this outcome. Then we learn these things. Then from that point, we change the outcome. We change the cohort of patient with a different outcome. Then we do from that point, we do the trial and we have this outcome. So we can't if the main outcome is changing, we can't combine the outcome and come to a conclusion, but it should be different cohort of the patients and with the different outcomes. Thank you.
Thank you very much for the very complete answer and explanations. I think this will be our last discussion for the first session. Thank you very much, Dr. Sukti, for the response and presentation this morning. Since we have reached the end of the first session, if I might conclude in very general statement that the clinical trials such as RCT, we might learn easily in the textbooks, but when we go deeper operationally or technically, there are many critical detail we have to conquer. So to prevent the bias. Once again, thank you very much, and please give a big applause for our speaker this morning. The second session will be writing for the international journals and will continue after the coffee break. And at this point, I will hand the program back to the MC. Thank you.
And thank you to our speaker and our moderator for the insightful sharing. And the next agenda is a coffee break and a rest period. And the break will last for 20 minutes. And those who would like to enjoy some refreshments may collect them in classroom E. Baik, kepada para peserta, jika ada ingin ke kamar mandi, ke toilet, atau ingin menikmati kudapan, jajanan terdapat di kelas E. And we will continue in 11:40 with our second session, and kindly be back on time so we can proceed as scheduled. Thank you and enjoy your coffee break and rest period. Never know. Unless we do. Kami informasikan kembali untuk waktu istirahat akan berlangsung selama 20 menit dan akan acara kita lanjutkan kembali di pukul 11.40. Good afternoon once again, everyone. And I hope you had a pleasant coffee break and are feeling refreshed. And we will now continue with our second session. Our next topic is writing for international journals. And publishing in international journals is essential for sharing research with a global audience, and it requires not only strong findings but also effective in scientific writing. And please join me in welcoming our moderator once again, Dr. Chandra Dewipayana Hamdin, and please give him a warm round of applause.
Thank you, MC, and welcome back, everyone. I hope all participants joining us on site or online are ready to continue. And with the second session. In this session, we will focus on writing for the international journal. Writing for the international journal. So this topic is highly relevant for the student, researchers, and academic who are preparing manuscript and aiming to share their research for the wider international academic community. And I heard I heard a key from Dr. Sukri just a minute ago, that writing is we couldn't teach to other, but interesting to hear the experience and probably some clue or some tips from the expert. Okay, without further ado, I would like to invite Dr. Sukri to deliver the second session. If everything is ready, then Dr. Sukri, the floor is yours. Please give an applause.
All right, welcome back again. Thank you so much being patiently listening to me and interactively engaging this discussion. This is also kind of very interesting and important topic we are going to discuss now. So again, it is, as moderator mentioned, this is not a thing I teach or someone else teach, then you follow, and then you apply tomorrow and you get your publication done next week. No, it is a kind of skill you need to develop. So as a lecturer, as an academic, we can share our experiences in publishing, our experiences we face, or struggles or shortcomings we face during publication process. But this is your responsibility to learn, to write, make mistake, from mistakes, learn further, and then sharp your publication, improve your publication skills. So it is not an overnight thing. But here I will be discussing few tips, few important points, which may be helpful in order to improve your writing skills, right? So please be in tune and ask questions, challenge me with the questions. It will be very interactive. So again, as usual, I will start with a question. Next slide, please. So my question is, why you need a publication, or why you need to publish a manuscript. So that is important to know the intention or purpose. So why you need a publication, why you want to publish a manuscript or paper, why? Share knowledge, good. Share knowledge with other similar or other community, other academics or broader people. Who said share knowledge? Who said? Okay, you deserve something. And So anything else? What I mean, everyone may have different purpose in order to get your manuscript published or your data published or research published. So right. So why you want to do a publication? Why you need to publish your work? Again, entertaining. Entertaining. Could you explain further?
Maybe because if we entertain about people can know us about our publish, not only my name. So it will be entertained.
It's kind of to be a famous. You mean? Okay.
I think beside the share knowledge, it's if we do publication, we can know there is in the other words some researchers do something that doing some projects that we can do different beside their project too, that we can do the different things that others do.
Thank you so much. So yeah, different opinions are there. One is like you have published your things, you will be famous on research world, and the second thing is you can understand what you do, what differently you do from other researchers or other academics or something like that. Any other? Because there's no any yes or no answer or yeah correct or wrong answer. So this is all your intention. I'm just asking why you want to do a publication. This can be anything. It's no correct or wrong answer. Filling the gap. Okay, filling the gap is important. So very common purpose, like we do the literature review, literature search, and we find the gap, and by doing a research, we fill the gap in research or in whatever. Anything else? Yep.
Can be the basis of policy for decision making if in the context of the public health.
Yeah, so generate some evidence in order to make the changes in policies and regulations or even in public health. It's very important too. So without evidence, you can't make changes. So you should have very solid evidence in order to improve the system, improve the regulation in policies. So policy change, if you want to happen, you need to do research, and research should not be just done and keep within your computer, within your university. It should be published so that people can learn or others can learn from there, and that can cause some policy changes. Thank you. It's important too. Any other comments? All right. Others, any other purpose why you want to do research or publication? All right. So last thing. Is there anything, any different thing you want to say through public? Yeah.
The other hand is for accreditation. If we are maybe teachers or lecturers, and then it's and publishing something, it's will make it uh, legal document, so it will long lasting.
Yeah, it's very, very important. Thank you so much for providing this insightful information about publication. Yeah, so publication can be many ways. Number one is a requirements maybe for your promotion. It's a requirement for your thesis. It's maybe your requirements for your program or your whatever you study, masters or whatever, or MPhil, whatever you do. But beyond that, whatever you do research should be proven that it's a good research by publication. Otherwise, if you do the research, maybe good one, but you still keep within your small circle or within the university without publishing, then you cannot be proven that the research is like very well done and very important. You are filling important gap. So many things have told like filling the gap are also important for disseminating the knowledge for others and getting the knowledge. And very importantly, whatever you do is the only way for academics, for researchers to be archived, to keep safe for global audience. Whoever wants, they can learn, they can understand, they can implement in their countries or in their projects or programs by publishing. So by publishing, even if you die, it's a kind of thing always remain forever your thing. So that is a big contribution actually. Even it's a small knowledge, piece of knowledge you invent, you understand, or you try to publish a small piece of thing that is very, very important, even for long lasting. Even if you die, somebody will read, is still cite, right? So sometimes I cite papers maybe done in 1940s. Those people may not be alive. So still they get citations. It means their knowledge is still being shared. As a Muslims, we believe like sharing knowledge is important. So it's a kind of, I can put into the Islamic word, it's a sadaqatul jariyah, that even if you die, the shared knowledge will remain forever. So it is not just a small thing. So as academics, as researchers, we can contribute our knowledge this way. Only way is publishing. So everybody should have very good intention that maybe this is a requirement, but it is more than requirements. It's for you, for your future. And then importantly, as a human being, as a Muslims, like we need to share our knowledge. So that is the platform for us in terms of publication. All right. So these are the few topics I'm going to cover throughout this one. As I said, I cannot teach you how to write. It is not, no one can teach you, but this is your duty to write, but I can give you some tips. So we will be discussing what are the mistakes normally we do and how we improve, what are the techniques we're supposed to use in terms of writing. Next, please. Can you go back to first one? All right, next. Right. So once your research is done, data being collected, now it is time for you to look at your data and then write appropriately, and then decide whether it is you fulfill the requirements of publishing that data or that results, right? And then whether the publication or manuscript is ready for the publication. Also, the criteria or requirements are fulfilled in order to publish the data. Next, please. So this is very important question. Just beforehand, I just want to know, so far, who has published any articles in an international journal so far? Anybody has published any data, any articles in an international journal? One. And who else? Who else published? Okay, two. Anybody else publish your research, your finding in an international journal? Right. So those who publish, you might have experience. It is not an easy thing. I'm not making you scared, but it is possible. But it's not just an overnight easy thing to do. But it has should have a lot of patience. But when you write the manuscript, when I write my first manuscript back in many years ago, I revised 11 times. I did first draft. I sent it to my supervisor. Comment. Second draft. Comment. Back and forth. So the 11th draft was finalized. And then I submitted to journal. But luckily, first journal accepted, went to review, and then he reviewed, and I managed to publish. And then with reviewers in the journal, I had a 2 times back and forth comments, and then feedback, comment, feedback twice. So ultimately, 13 times it was reviewed by someone else and then published. What I want to say, as a junior researchers, as a beginners, you should not be disappointed if you have a lot of multiple sort of revisions required by your seniors or your supervisors. That is all about, not to say you are not good, but rather than polish your work until you get a point that is standards are met, right? So my question is, very important thing is, most of the time, in my experience, even within my students and even my own experience, as soon as you submit your articles, your manuscript to a journal, maybe next day, so within 24 hours, even before going to reviewers, from editor, it comes back to you saying that, I'm sorry, thanks for submitting. We regret to inform that we are not interested to consider your manuscript to publish in our journal. So that is very common email we all receive within 48 hours from the editor. So most of the time, especially with the junior writers or junior researchers, this is very, very common email we receive as soon as we submit a manuscript to a journal, all right? And again, don't get disappointed. This is very common problem with everyone, right? Now my question is, why we get this one? What is the problem with that? Why it is our piece of work can't go, pass through the editor to the reviewer? So what's the problem? Why it is happening? So that is very important to understand, so that when you're writing your first manuscript, you can overcome that issue. So what do you think? And then I will have my own discussion on that. What do you think? So I hope you understand the question. My question is, when we submit our manuscript to a journal, most of the time, the manuscript won't go through editor. It comes back to us saying that, sorry, we can't publish. We are not interested to publish in our journal. Something like that from editor within 24 to 48 hours. It is not even passing through the editor to reviewer. Right. So my question is, it's very common, very, very common. So why it is happening? What do you think? What's the reason maybe for this particular rejection from the journal, or not even journal, like editor, before going to the reviewers? We are not meeting the scope of the journal. Yeah, maybe. Yes.
Any answer from this side?
Any other different thing? Again, you please talk. There's nothing like correct answer or wrong answer. This is all what you think, what you think, or what you experience, or what you think is to improve. So don't hesitate to say something.
Maybe because inappropriate topics.
Yeah, maybe topic is not correct or not. Yeah. Any other issues? Sometimes what I think may be different than you think. So I need to know your thinking. Maybe different thinking has together will help to improve our publication chances of publishing our data.
Maybe another reason was over-publish about some certain topics.
Again, can you repeat, please?
Over-publish on some idea that is.
So it means already published. Yeah, already maybe published.
Maybe some lack of novelty. Maybe same as the and then methodologies issue maybe is not right, and it's about the conclusion, and then what pelaporan pelaporan structure of the report is not coherent with guidelines that with the journal is not correct, not follow the guidelines. Okay, maybe.
Thank you so much. These are the very important points she mentioned. Like, the very silly mistake we make is like when we were submitting our manuscript to the journal, we don't read. We are in rush. We don't read properly the guidelines and not follow the formatting requirements. It's just we submit. That one of the reason. Another reason is lack of novelty. So we may, or sometimes it is novel, but we are not expressing the way. And then also the coherence way of writing is not there. Lack of the storytelling way. So these are the very, very, very important points. Always we make, we compromise with. So that makes rejection of our publication even before going to the reviewers. Any other important things? Sorry? Yeah, ethical issues, maybe. Yeah, ethical considerations, ethical issues. Any other?
Maybe because it does not meet the standard of the journal publication, please.
Yep. So they maybe it's not the correct audience or correct is not meeting the standards of the journal's requirements or publication requirements of that particular journal. Is there any last point before I discuss this issue?
May I?
Yeah.
Yes, thank you, Doctor. So I experienced that I experienced my manuscript was rejected because of overclaim somehow, overconfidence, and so probably how do I explain the result of the experiment just too much for them? Then they give me some suggestions and they give some command on it. But the key is overclaim for the result.
Yeah, that is also one of the reason. Like we like our research. We are very proud of what we do, and we want to overclaim. For example, this is groundbreaking research. We change the world by this research. So we kind of using kind of very extraordinary words, and then saying kind of overclaiming our work that may push down, this is not that much what you are claiming. This is something different. Yeah. So these are the, already right? These are the important things. So I'm going to summarize what you just mentioned, right? So these are the main, I think if you are interested in publishing next 6 months to 1 year, I think you must listen to these basic things, right? Number one, if you want to get through your editor, I'm also editor for a few journals, so I know what's the problems and all those things. And also, and I also face many challenges when we submit the articles to the journal. So number one, as you mentioned, one of you mentioned, the first thing you spend some time, you spend some time to understand the audience of the journal. You just not randomly select the journal. What is your research area? For example, your research area is about public health issue. then you should not go and submit the journal to publication to something else. The audience is different. So you can't submit that article into kind of clinical journal. So you need to select the journal according to your research area. So you can't randomly select. So that is very important point. So you can justify that, okay, my audience are this one, that journal has the same audience. So this is number one. So don't select your journal based on the impact factor. Impact factor, of course, need to consider, but within the area, within the, your followers or readers who read that journal. So audience is important. So please select the journal according to your research area so that that can be your audience, number one. Number two, it's very, very important, very small things you can correct. Number two, you have to read correctly the guidelines of the journal, requirements, formatting, small thing. They say, use the reference by this way, do the spacing like this, numbering this thing. So you just 100% follow the instruction of that journal so that they will not get annoyed by this person, though this is good one, but they don't have patience to follow the instruction. So that is an important issue. So if you don't follow the instruction or guidelines of the journal, how to format, this is not how to write, how to format the things. That is very small thing that make push back to you, like saying that we are not interested. Number three, most of the time, we try to write the things very sophisticated way, like using very big words and all those things, trying to make it like a very high level, very big jargon, word jargons using. So that is not the case. Here research, right? Research should be written clear, very clear way, simplified way. Don't need to use like a big technical jargon or technical words, but use very simple word very clearly. So writing should be very clear, very simple and very clear. So you write your manuscript clearly, very simple way. So in that point, how you verify your writing is clear, and then simpler way means even the person who is reading your article, who is not from your area, for example, not from public health, should understand, should able to understand your research, right? To overcome this issue, clarity, simplest way of writing. So how we can do, or how we can improve the simplicity and then clarity of the writing. So I do some way. So I want to know how you can do. Then I can share my way of improving the clarity and simplicity. You want to say something?
Maybe for the abstract, they can see our research from the abstract.
Mm-hmm. Yeah, so abstract is a reflection of our article, whole article, that one thing. So my question is, I said the article or manuscript should be very simple, very clear, and then person who is reading, not from your research background or your research area, should able to understand. Now my question is, how you verify the simplicity, clarity of your manuscript? After you have written, before submission, you want to verify whether it's simple, clear, anybody can understand. So, so how you verify that way, that thing?
No, I was a bit confused with the question. So do you mean like ways like asking our peers to read the manuscript, or the way we write?
My challenge was, like, most of the time, we use like a big big jargon or different way of writing. But I said one of the main reason is get rejected is simplicity is not there and clarity is not there. So it should be very clear, very simple way of writing. So to get this one done, after writing, how you check these things are met. How the way of checking whether your writing is clear is very simple. What's the way? How you check? So I mean, it's not like a technical thing. It's a very simple thing. So I have a way. So I want to know how you do.
I usually ask one of my friends or peers to summarize my.
Of course, very simple. But I asked my friend who is not a medical background, who is not a academic, but he can read and write English clearly. So I give to him, and then I ask to read and then comment. I honestly saying that my friend who reads, who is not an academic, who is not a researcher, and give feedback is very valuable than any peer reviewers who has background of my research. That makes the difference. So please, when you write your manuscript, you rely on your peers, that's fine. Peers will give you technical feedback. But once everything is finalized via technical things, you give to this manuscript a person who is not a researcher, not a clinician, not an academic, but who can understand, who can read your manuscript, then his feedback or her feedback is important to improve the clarity and simplicity of the manuscript. If he can't understand, if he can't clearly understand the things, it means something wrong. Or if she can't understand or there's no clarity for him, it is something wrong. So you can improve. Fourth thing, we write, we have very important message, very novel message, right? But most of the time, we forget to make the storytelling flow. So that is most of the researchers, most of the academics, even senior academics, lacking is storytelling. So you don't take it a very serious thing. You think you want to say a story to someone, then make a flow. Don't jump here, there. So it's like a storytelling, a flow from beginning, planning, and then objectives, and then method, how you do and what you have done, and then based on that, what you discuss, and then conclusion. Should be a very clear, smooth storytelling flow. Then if you can maintain the flow, that's it. So write first manuscript, read, and then rewrite whole thing, make a story or a small story with a good flow, coherence. It should be there. So don't put here, there. I mean, so that will make the reader or even editor confused. Sometimes you have big, very important message, but the flow is not there. So clear, coherent way of understanding or writing is not there. Then even though you have very good message, you are not able to convince that. So that can be done. How you can improve? You write, read, rewrite, read, rewrite couple of times, and then your peers can help you. And then some good senior authors who has experience in publishing many articles, they can help you with the flow. And then also, of course, non-academic person can also help you to understand whether you are making him or her understand your thing. So, and then the fifth thing, sometimes editors, they have no time to read a full article. So they read your abstract, also cover letter, right? So this is key point. Don't just copy the cover letter from your last submission and then put some changes and submit. Cover letter is very, very important. The first thing the editor reads is your cover letter. So far, I'm not talking about how to publish the thing. My point here is how to pass from editor to reviewer. How you push the publication from editor to reviewer, right? So the first thing is cover letter and your abstract. Abstract, you spend hours, no problem. You spend days, months to write the manuscript, very clear manuscript, but you don't spend time in writing 250 words of abstract or 300 words, enough time. You rush and put something and submit. That makes your life's disaster, because abstract is the first thing reflecting your manuscript. And then cover letter. So these two things should be very carefully planned, written, right? So cover letter, like you can share like how you do. Then I will share what I do. Even academics, you can share your own, because that is beneficial for audience. So how you phrase your, not exactly phrase, what are the things you consider when you are writing your cover letter? You want to say? You want to say?
Maybe the cover letter must be the specific, persuasive.
Specific to the research area or journal. Yeah, okay, yeah. Okay, persuasive, okay. All right, any other thing you have to consider when you are writing your cover letter? Right, so cover letter is the one telling to the editor, and the editor is the reading, the first reading your cover letter to understand this piece of work you are submitting is targeting the audience of that particular research area or research journal. You have to mention this one, right? The number two, the novelty of your work. So this is novel piece of work. You are filling the gap. One is target audiences should be mentioned, and the novelty should be mentioned. And then it should be very precise, not more than 1 page. That is challenging. If you write 3-page cover letter, no, it won't work. Everybody is busy. They don't have time to read 3-page cover letter. Should be 1 page max. But two things should be highlighted. One is your importance of your work. What is the new thing you have, or an important thing? What is the gap you are filling? And then which the piece of work you are submitting is the target audience to that journal. So if public health journal, so you should able to say, okay, now my next question, anybody can write some simply, okay, this is important part of work I have done, and this is targeting the audience of your research, your journal. Do you think they will convince by this way? No. So it's not like just writing. So how you make a smart way of saying, this is piece of work, which is targeting your audience. So how you say, how smart way of convincing the editor. So I have a small technique for that. How to convince?
Ya, pertanyaannya bagaimana meyakinkan editor bahwa riset kita ini cocok untuk jurnalnya, dan apa namanya di masa depan itu bakal dibaca oleh audiensnya jurnal itu. Mungkin yang ditanyakan lebih fokus ke the way the praise the sentence.
Any comment or any suggestion like how you can tell your editor in convincing way the piece of work you are submitting is targeted audience, journals audience. It's a focus on journals audience, whatever the field, maybe medicine audience. It's not just writing a sentence. It's should be very persuasive way. Any suggestion? All right. So my technique we use. If I have a paper already published in the journal, I cite in the where in the letter saying that. So and also I purposely put more reference from that journal in the manuscript. Number one, I highlight the paper which I have already published in that journal. So based on this one, and also purposely, for example, I want to write something, I have many references. I can't put 100 references one sentence, but I will select the reference which is from that journal. So that means I have a list of references from that journal. So that is indirectly telling this is relevant for the audience because all the references also from the same journal. Number two, I purposely put my publication. So I will say, according to my publication, BMJ, blah, 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 this was next step of my work. Then it's indirectly saying, okay, he has already published in this and he's not going to update the things. Okay, go. So this is the way I put. Otherwise, I mean, if it's the first time you are publishing in that, then I can use a word saying that, according to the reference list, I found this is relevant to your journal because all of the out of 30 references, half of the reference from area of the public health, something like sentence with evidence. So then it is, it's relevant. So we are like pushing him to think it's relevant, right? Don't just say, this is important because we are submitting a public health work. No, it won't work. Should have some evidence in order to persuade him to think or her to think it is relevant to this journal. Did you get my point? It's very important. It's a small thing, writing a cover letter, but these are the few things you have to consider. If you have any question, I don't worry about the time. I'm happy to answer.
Ini because this is like a key tips, so I need to translate for better understanding. Salah satu tips dari Dr. Sukri adalah dia selalu menulis di cover letternya itu, dia mensitasi either hasil penelitian dia pada jurnal tersebut atau hasil penelitian orang lain yang relevan dengan update keilmuan yang akan disubmit, penemuan barunya. Lebih bagus jika ini merupakan hasil penelitian lanjutan, sehingga tidak ada pilihan bagi editor selain oke, lanjut ke reviewer. Itu yang saya tangkap. Thank you.
The next part is now cover. So I have mentioned the cover letter. Again, I'm highlighting cover letter will be very simple, maximum 1 page, but it should able to convince the editor this is important, this is relevant to the journal. So I have mentioned something to how to mention. Now come to the abstract. As an editor, how I check the quality of the work or quality of the person who is submitting the work by looking at the abstract and then quickly skimming through the objective of the manuscript and then conclusion of the manuscript. Then be careful in the abstract. If you put something conclusion and then objective different than the manuscript, it means you are not doing the job correctly. So this is inconsistent. So the abstract should be reflecting your overall manuscript. So very simplest way of checking that, I always jump into conclusion part of the manuscript, also objective or aim of the manuscript, and then look at the abstract based on that. then if I'm not convinced, like that is not matching with the abstract and then main part of the objective and conclusion, I would say so I would say this is may not be relevant. So abstract should be very simple, but should 100% matching with the objective of the manuscript, also conclusion. You can't conclude something else in the manuscript and conclude in the abstract something else. So a small piece, but should be 100% matching with the manuscript. These are the few things I follow when I'm writing the abstract. All right, and sometime, so we are not native speaker. We are not native speakers. So we always or we often make mistakes, right? So, but when we are writing, sometimes we may copy paste from here to there to here. It is common, right? So I would say one very good example. I was working in one of the big projects, is tobacco control projects with the big projects involved in 20 countries. So, and published in very good journals. So I was working, when I was in Malaysia, I was working in that project. So after 20 something publication, one editor found a silly mistake, which was in all 20 publications. We published 20 plus publication. When we are publishing the 21st or 22nd publication, at that point, the editor found a mistake. That was a silly mistake. Then that mistake is there in our previous publications. And publication involving Canadians, UK, US, many experts. But the error, the mistake was throughout 20 publications. What does it mean? What does it mean? What does it mean? I'm saying when we published 20th publication with the collaborative researchers, we found a mistake, or we didn't find, but the editor found that mistake was all in our previous publications. What does it mean? Do you understand my point? So, I mean, when I was working the tobacco control research with the many international so the group was publishing many articles in good journals. So it was like a 20th or 21st publication. When we submitted this one, editor found a mistake. It was in previous all the publication. What it says? What it says? What is the interpretation from that? Sorry? Okay. I mean, there's a very small mistake, but it was consistent all throughout. So what it says, what is interpretation by that way? All right, very simple. We were copying standard of writing in every publication. We just copy from there to here, and when we copied the 20th, we found there was a mistake copied from throughout. So this, same language, same was done. It's not a mistake of copying because our own writing, because it's a part of the statistics of that the journal writing. Method section in the method, something like statistics. There's a silly mistake was there. It was there in all the publication. Later, when we come to 20th publication, we found it. So why is happening? We just copy it. Now, my point is here. Sometimes we do silly mistake by copying things without having knowledge. For example, journal clearly says you use British English. Or sometimes journal clearly says you have to use US English. But when you're copying, maybe you copy from English, from British, English from what you call US or something, and then all mixed up, then that's going to be very big indicator when this is when comes the reviewer. When reviewing the paper, they will say, oh, this person writing British English, again writing US English, is something wrong. So that is a negative impression you are giving to the reviewer. So you pass the editor now with the reviewer. So just try to be consistent in your writing using whatever the requirements by journal. If you want to use English, British, change it. Purposely look at the way, English font, in English, whatever thing, style. That is one of the key thing. Reviewers get annoyed when they look at the paper when they are reading. And then next important thing with the reviewers, sometimes when we were writing the paper, when we are writing our articles, we know about our research. This is in our head. We have done the research. We have analyzed the research. So it is for us like everything is clear. But when third person is reading, they don't have mental status or they don't have background knowledge about your research. So based on our background knowledge we write, we think the reader may have the same knowledge about your research, so they can easily interpret. So that is not the case. When you are writing, though you are expert, you know about this, but you should think you are saying something that person know nothing about your research. So it should be very clear message, very clear message. Forget about you know the research, but you are telling a child or some person, someone who does not know anything about your research. So when you're writing, a mindset should be very clear that you are not telling to yourself, telling someone who doesn't know anything about your research. So that is very important. So again, that comes to the clarity. Clear message should be there saying that audience are not expert or audience or who is reading this one, they are not the part of your research group. They don't know anything about research. So then when you think in that mindset, when you're writing, then you are able to write something other person. Otherwise, if you think writing with your own mind, you know everything, so it may not come with a flow. So clarity is important. Again, sometime when we finally formatting the things and all these things, these are the very silly mistake we make. Like, the final, when we submitting the articles to journal, we kind of very rush. It's normal. We want to just push the articles to be submitted. Then we don't forget about maybe final touch up, finally fixing the references. Then you don't carefully, we normally don't carefully check all the references are correct and updated. So that is one of the things, reviewers get annoyed. Then that is chances of pushing back. So please, this is a simple things. Reference. Once you finalize everything, take your own time, check the references which are correct. When it comes to the references, other issue with most of the time, but that is kind of not badly impacting, but it is important too, but you will get a reviewer's comment. Look at the references which are relevant, also updated. Sometimes you are writing something and putting the reference which is outdated. So that is not relevant at all. So there should be updated ones for that particular area. So always you should have updated references. So maybe someone say something in 20 years back that is not relevant now. So you can't use that reference at the moment, right? So you always come with, or put your references with the updated information, an updated reference. And again, reviewer point of view, you always these are the very simple things. When you putting diagrams or tables and all those things, you should clearly link that information with the text. Sometimes we are very busy, we just write, but we are not linking. Sometimes this table is hanging there somewhere with no linkage. So this is a very simple thing. You have to link when you are writing those tables and reference the figures and all. Always, when we are writing, always our text or our word are limited. For example, sometimes some journals say maximum 3,000 words. maximum 4,000 words, 5,000 words. So you have to write within the limit. So, but you need to give more information, but we have limited this thing. So that is not a problem. But what I always do, and also limited tables and figures. Maybe some journals say maximum you can have 3, 4, 5 figures or 5 tables, or maximum this much tables. So, but still, we want to convince the message. So I always have appendices. So I put more appendices, so that is not counted, but always with a link. So according to appendix A, these are the information. According to appendix B, these are the info. That is not a part of the table, part of the figure, but I add as much as, so that if they want any clarity, it is there. For example, when I writing the method section, I would say, okay, statistical analysis done comparatively, logistic regression, and then this variable is that, and direct variable or indirect variable, all these things, and adjusted this very, very professional way I write. Then I put details are available in the appendix A. Then in the appendix A, I will put all the details. What are my independent variables, how I select, how I coded, and then what are my dependent variable, how I select, how I coded, what are the assumption I made. All the details are there. You don't put these things into your manuscript. That is wasting your number of word count. So your word count should be important in order to write your research and discussion, and then the conclusion. That is new things. But all the method section, you can write the details in what you call appendices. So, but you have to link that one. Appendix A details are there, but you mention the things what you have done. How you have done is appendices. And then next important thing is flow. Don't let the reviewers to jump up and down to read and understand your thing. So if you start the what we call manuscript from the aim and objective, when the reviewer is reading through your manuscript, should be a proper flow. Then once read, then you should not let the reviewer go back, read the what we call method section, come back to research and go to jump into the discussion. No, it should not be a way of writing. It should be a proper flow. So it is not necessary for reviewers or anybody who is reading your paper should not go up and down to understand what you write. So it should be again clarity and then proper flow. And so next, please. Sometimes, most of the time, I find the publications are not accepted, or mostly can get rejected. It's the basic things, not the big things. Sometimes we have good data, very important data, but we are unable to mention like a logical way, right? Ensure that every section from the title to the conclusion flow the naturally using the storytelling approach. As I've been telling, should be a very simple way from title to the conclusion. So if you are able to write this way, that is right. And a clear message, clarity is important. The provided useful and exciting message that reads, grabs in the first few minutes of reading. And then of course, it is very important. We have to very clearly mention the importance or significance or novelty of your work. It should be clearly mentioned, right? Its strength, novelty, or importance of your work. So it should must be mentioned somewhere in the manuscript, mostly strength part or wherever. Next, please. Right. Again, so based on your data, so when you are deciding which sort of article or type of work you have, based on that you have to decide you are going for a systematic review or full article or a letter or something like that. So this is a summary or short communication or comprehensive research article. So if you have something small work, so if you are trying to submit into a big journal with a detailed full article, that's not the case. So you may end up like a letter to the editor. So based on your nature of the work and the quality of the work and amount of the data you have, based on that you have to decide which journal or which type of communication you are going to do, right? Next, please. So again, the same thing. So examine the 3 years of study evaluating the long-term effect of a new pharmaceutical drug across the multiple diverse patient and then demographic. And this is one type of research, 3 years, and then high impact discovery or computational review. So based on the type of the research, you need to understand which type of the article or manuscript or you should able to write and submit. Next, please. Right. That is again, so you have written the paper, your abstract is clear, your manuscript is very nice, right? And then is flow is correct, no errors, no grammatical errors, no language problems, no any issues. Now the next step you are going to do is selecting a journal to submit, right? Now I want to hear from you in your practice, normally how you select the journal which can be publishable. So how you select your journal, which journal you're supposed to going to submit your work? Any idea how you select your journal to publish your work? I mean, if you haven't done this one before, just what do you think? How are you going to select the journal which is relevant for your publication? How you are going to select? Any technique or any sort of way you do?
I think first thing first, I need to match my budget first, because some journal required fee for publications for submissions first, and the second is trying to look for the scope of the journal is also matching with our scope of with our articles in this case. And the second one, then and the third one is, I think I look for the quality of the journals that we will be published our article, like the Scopus or Copernicus and other things like that. I think, or also, is there any additional requirements that we need to fulfill before publishing our journal, publishing our article in certain journals? I think that's all.
Yes, yes. Important thing is, of course, some journals are very good, but the charge is also very high. So according to our budget, you need to consider which journal you are going for, and then other things, right? So yeah, so relevant audience are there, and then importantly, you sometimes some journals they show very high impact. Like if you look at the impact factor of the journal, maybe 4, 5, 6. But if you look at the quality of the journal, maybe not there. So that is also important, as he mentioned clearly. You select the journal. After that, you can check the quality of the journal. If the journal is not the high standard one, so you should not go for it. Sometimes it may show high impact factor, but it's not the case. But unfortunately, I want to say this message because it's like an experience I had with one of my colleagues. So what happened in somewhere, I don't want to mention country or anything, but he was one of my colleagues. So the few colleagues together, they started a journal. Within a year or two, the journal was hit very high, like with a lot of impact factor and this and that. Then also these people who started the journal had a lot of publication, like within 2-3 years, maybe 30, 40 publications. It's very exciting. Then journal also boom, like very few years time, like it's big, become a like very high impact journal. But all of a sudden, everything was collapsed. And then that academic who started journal, he lost the credibility of the academics. He lost the job as well. So, I mean, you can understand what I mean, like indirectly. So this is the thing. Sometimes some journals may show very good, but then end up with some kind of, unprofessional things happening behind the scene. So you should able to check the quality of the journal is important. Right. I have some few ways, and also University of Sydney highly encourage where I'm from is like selecting the high impact journal and quality journal. Otherwise, they won't fund you or help us to submit and then pay the fee. Right. So again, when you're selecting, you can check the references of journal, I mean, previous publication, then you can decide is suitable. And then how fast they are publishing. That is also important, and target audience and quality of the journal. So I have, again, very bad experience. We submitted an article to a journal. Then we got the reviewer's comment. We responded. Then after that, no message. 1 month passed, 2 months, 3 months, 6 months, no message. Then we wrote to the editor. Then they said, we missed it. Sorry. And then we got the again some feedback, and we wrote back to them. And then again it took some time. Like overall, it took at least 2 years for them to decide. So then from that point, we said, no, this journal, though is a good journal, but you can clearly see the processing time. Look at the processing time also. That is also important. You should not wait like 2 years or 3 years to get for them to process the article. So look for the journal, high quality, lower processing time. So 2 to 3 months should be okay. But if 6 months to 1 year or 1 year to 2 years, you should not go for it, right? So quality of the journal, processing time, and then target audience. Your research is targeting the public health people, then the journal also should be the same. So that can be looked at by journal previously published articles. Next, please. So again, selecting the journal is important. Selecting the journal is important. So I would say you should follow some guidelines, which correct whether you are selecting the correct journal. So number one, you can look at your references, and then based on your, because you are writing and you are referencing, those references should be the journal which is relevant to you. So then one way. And then expert consultation, you talk to your supervisors, experts. Then based on their input, you can finalize your journal. Number 3, author's guide review. And then digital analysis, and then final selection. So based on all these 4 criteria, you follow these criteria, or you may follow the similar criteria, and then you can come up with your decision. So what is the digital way of checking digital criteria? So digital analysis, what is that? How you can do digitally check whether you are submitting or going to submit is appropriate for your work? Any clue? So others are very obvious. You look at your references, talk to your supervisors or seniors, and then third one, author's guide review. Look at the author's guide, and then digital analysis. What is that? I just want to highlight a few things about digital guide. What do you understand so far, or you have any clue about that? Anyone? Sorry, you're saying something? No. Okay, so they know already. Yeah. So yeah, yeah. So what I'm here highlighting, you should not just think, oh, I may go for this journal, I may go for that. No, you should not think. It should be a systematic way of finalizing the journal where you going to submit, right? So these are the few things you need to consider. One is your references, and then expert opinion, and then guidelines, and then digital way of checking. Based on all these four, then you can decide, okay, these are the number one, number two, number three journal I'm going. So once you finalize the journal, again, you have to check the quality of the journal, impact factor of the journal, and then decide. So, okay, next step, next one. Okay, I think that one maybe next slide. I will discuss that one later. What are the digital way of checking? No, yeah, so correct. So ethical submission. So it is very, very important. So most of the time, we unable to meet this criteria, but it must be met. Once you finalize, you can submit your work into one journal. At a time, you can't submit more than one journal and look for the luck. So no. So when you submit, just wait for the response. If rejected, then you can approach the other journal. Not the same time you are approaching many journals. That is number one. And then authorship. So there's a very clear message or clear documents in the journals and in the reference this thing. Who will be author? Who can be author? You can't just say, he is my friend, she is my friend. Or you can be author, he can be author, and then many authors. No. The author's responsibility should be claimed in the paper clearly. So you can't decide just because of the friends or colleagues or something like that. So authorship, it's also part of the submission ethics. Authorship should be claimed based on the contribution. If the person is contributing to your work, that should be claimed, right? If not, maybe he can or she can acknowledge. And then part of the ethics requirements is acknowledgement. Who is funding your paper or your work or research should be acknowledged appropriately. Who is contributing? For example, you're working with the doctors or pharmacists or someone else helping in order to collect the data, then should be acknowledged. So these things should be acknowledged. Those are ethical consideration. Also, the word called data slamming or something. I forgot the keyword. So sometimes we have very good data, then we cut slicing into small pieces and one publication, second, third publication. No. If you can publish a whole story in a good journal, that is a good way. Because of you want to increase the number of publication, you should not publish in same message, but using different little data set. So it should be like a data slamming or something we call. So it should not be there. So then, as I said, you can always withdraw the publication because if it is slow, more than taking more time than required, then you have to have a formal withdrawal. Without withdrawal, you should not submit the journal publication, your manuscript to any other journals. Now, I have to mention this thing also important. Now, AI is everywhere, right? So AI can help in many ways, but AI cannot replace you. So your work should be written by you, but of course, AI can help you to improve the quality of the writing. Like for example, we are not native speaker, but you have to mention what sort of AI expertise you got into these things. But that should be ethical consideration. Again, you can't ask the AI to write whole manuscript and then submit. No, it is not a way. You have to write because you are the one who understand, you interpret the data, you analyze the data, you collect the data. AI can help you in order to improve your writing by checking the grammar and punctuation, this and that. Next, please. So as you know, these are the main basic things in the manuscript. All the area section of the manuscript. So you have to follow according to the guidelines. Next, please. Also, I think I forgot to mention earlier the title. Again, when you read the manuscript, the title is an important part of the manuscript. So title makes some more decision than your abstract. So title should be reflective of your work. It's not something unnecessary or irrelevant thing. Should be reflecting your work a clear way. So you should able to write your title clearly, reflecting your work. That is very, very important. You discuss with your supervisors, your seniors and experts, and finalize the quality of your title. That is very, very important part. So, for example, action of antibiotics on bacteria. That is one title. And the revise the inhibition of mycobacterium tuberculosis by streptomyces or something like. I mean, something title should reflect your work. Next, please. So again, I have mentioned already, remove unnecessary wording, remove unnecessary things and focus on the clear, the clear message. And then identify the specifics like define the specific drug type and all those things. Peer review should be done, written, rewritten. Next, please. So it is important that once you publish, it is once it's published, it's not just to purpose of publishing. It should be disseminated. Yeah. But if you have enough funding, yes, you can publish open access journals. So that will have a broader audience. They can read, they can review. That is also important, improve the citation. So as soon as you publish your work, you should able to disseminate at least by yourself in the social media and all those things. That is also important. You should not just keep in with yourself. You just share the message to your colleagues and through your social media, whoever, right? And then the citation is important for you, for your career, for your institution. So it is very important so that if possible, yes, publish in open access journal if resources available. Otherwise, you maybe partially or institutionally supported journals and all those things. Next, please. So abstract guide we have already discussed. Next. So introduction is important. Identify the gap. So in the introduction section, when you're writing, you should clearly mention the rationale and the gap. So then based on the rationale and gap, you should able to say your aim of the work. So introduction part, yes, again important. And then don't write a lot of history about, for example, if I want to write about TB, should not write about TB history. TB was found this much, that much. No need all the story. That focus on your work and relevant to the work. Next, please. Next. Again, as I mentioned, should be novel. If it is something not new, then you should not waste your time to doing the thing, but make changes and make the improvement and you do the work. And then control the required and then specify the matters. Don't dilute the work or saturate the work. Next, please. Again, the visuality is important. Graphics, photos, color, and then secondary things. Consider including all these things. Next, please. As I mentioned earlier, whatever the tables, whatever the narratives you mentioned is clearly used very appropriate way. So very common mistake when you're writing, we all make is like decimal points and all. Sometimes one place you put 2 decimal point, other one decimal point, 3 decimal point. Should be whatever the unit, whatever the things you write is be consistent throughout the paper. These are the minor things. Next. Turning your data finding into the narrative. Yes, so we have different data, but should able to write a clear narrative, to clear story from your data, from your overall interpretation of your work. Next. So your conclusion should be from your work, not overestimating. For example, based on my data, this is the conclusion. You can't conclude something, your data is saying something, and then globally. So based on my study, globally, I can achieve this one. No, it's irrational or inappropriate conclusion. It's conclusion driven by your research and discussion. From that, the conclusion based on your data only. Sometimes we fail, we are overconfident, and we think we have done something globally impactful so that we can implement, you say, I can implement globally, something like that, or shouldn't be then. So it should be focused on your data. Next, please. Again, so reference part should be important, and you should follow the guide according to the journal's guidelines. Also, relevant references, recent or updated references. Also, if we have something already you publish that is relevant, you better cite your own work. That is also bring your reference or citation up. Next, please. Navigation of the conflict of the interest and ethics. Yeah, so whatever the conflicts of interest, you have to clearly mention. For example, you are getting some money or industry support or something like, funders or someone supporting your work. So should be declared. So all the conflicts of interest should be declared. Don't need to worry about that. Personal motive or something like any conflicts of interest throughout your research should be clearly declared in the paper. Next, please. So cover letter we have discussed. Next, please. Yeah. So again, if you are, I asked earlier, if you are first time you are publishing, remember this in your mind. You use your name or in the manuscript consistently. Like for example, if you have two parts of the name, so if you are writing your first name first, second name second, you keep whatever the upcoming publication same way. Don't change because the system may not identify you later. And also immediately first when you are submitting your first, before submitting you open your OKIT or OSID registration, you get the OSID number and then keep that OSID profile and put that OSID number in every publication so it can be automatically get that together. You have your OSID kind of reference. Next, please. Okay, this is the one I was stealing. So next, please. So I have bit running out of the time. So already time's up. So I'm rushing through. So these are the different ways. So University of Sydney encouraged the Jan way. You type in a Google like Jan, then it will pop up this one. Then you just copy the abstract into the Jan. Then it will give you something like this, potential journals. So first we do other three things: reference, advice, and all those things. Then fourth thing we do, you go through Jan and then submit the abstract, and it will give you a list of possible journals which we can approach. So based on all these 4 criteria, we select our potential journal to submit. So some other institution, they suggest Elsevier Journal Finder, EndNote Manuscript Matchers, Springer Journal Suggester. These are the different options you have. So I recommend Jan method. So it's just not much, it's up to you. Whatever you prefer, you use. So at least 2-3 way of finding the correct journal. Next, please. So audience, yeah, you have to follow the think or consider your audience when you are finalizing the journal. Next, please. Again, I said always if you go for gold open access or green open access is the best because you will have a lot of readers, a lot of citations if you have option. If otherwise, you publish in the not open access journal, but you disseminate the message by social media and share your work to others. Next, please. So this is my last thing. So your success is publishing part is all this together. Thank you so much. I think that's it. Next. Yeah. Yeah. So again, I just want to summarize. Publication is something like you learn and answer the question. It's a like process, right? So you may have some idea today. So you may have some different ideas from others, and then together you try, you write, rewrite. By the way, by writing, rewriting, you may publishing, you may end up learning more and then sharpening yourself, right? And if you have any few more questions, I'm happy to answer. Thank you so much.
Thank you so much, Dr. Please give an applause for Dr. Sukri. Thank you very much, Doctor. So we are very appreciated because not only the presentation but also the experience, the experience in publishing the journal or article to the journals. We will now go to the discussion part. If you have any regarding the publication process, writing process, actually, what Dr. Sukri explained are beyond his PowerPoint, and he shared everything he had, and this is what we call in Indonesia in our bahasa ilmu daging. So everything is very important because we've never know until we do it, until we experience it. But we got it already because Dr. Sukri told us today in this afternoon presentations. So if you have any question or concern about publication, just raise your hand for both of offline or online participants.
Okay. Good afternoon, Dr. Sukri. My name is Pangestu. I'm one of the first year general surgery resident here in Mataram. Before, I would like to thank you for your lecture and about improving our publishing skill. And I find it very intriguing for us to know the point of view or the insight from the reviewer itself. And I would like to focus on the writing skill. My first question is, as you say earlier, writing skill is something that not simply can be taught. So, as a novice writer, what is the most simple or practical thing we can do to improve our writing skill? And the second question, if I may ask, when it comes to academic or scientific writing, how do you usually decide on which topic or idea to cover? Because does it always have to be like sophisticated or high impact, like or new novelty, or maybe because I found it very hard for us a novice writer to find an idea or topic to cover on. Thank you.
Thank you so much. Again, the question is very interesting and important too. Thank you so much for raising this question. So come back to your first question. Yeah, as I mentioned, it's not like things we can teach you how to write, but how to improve, yes, it is possible. So even myself, also senior to me, back in Australia, maybe professor level, we every year we have we call differently. Sometimes we call it shut your mouth and write. So we kind of people, 10, 15 people sit whole one day, and then we switch off the phones, everything. But expert, we sit in one room. I write my thing and others write. Then we have break. Every 3 hours we have break. And there will be juniors, seniors, all. And then we discuss. Like, for example, I say, oh, I share my writing with, maybe we write, maybe not whole paper, maybe a part of the paper, maybe introduction. Then I write and I share with other 6 people or 10 people in the group. So that dedicated day, whole day from 8 to 5, we don't do anything other than lunch and whatever the break, we write. Then we write to learn. Then we share. Then every other people, maybe seniors, juniors, they give feedback. Then we improve. And then we give feedback to others. So this is the one of the ways we implement at the University of Sydney, improve our writing. Even not only me, I'm also like a middle career person. The seniors, the professors, they also come. They write. They show it to us. We give feedback. So by the way, mutual learning. So by mutual, then in that time, like that process, even sometimes very beneficial, because the simple things we don't care, but journal cares. So that we get from them and learn, and we never, so once we learn through that process, I feel like I never forget to, think when I'm writing those important things. I mean, I can't say any way which is correct way, but I'm just sharing the way we do back at University of Sydney. This is a process. Every 6 months, at least twice a year, we sit and write. So that will help us to improve writing skills. And then university level for higher degree research student, they have a week of writing workshop. In that, what they do, different experts come every day and then make the students to do literature research, literature survey, and then ask them to write the objectives. Like it's a workshop. So they that the university level or administrative level they can think of. So they have like for example, you have research method sort of workshops or course, something like that, writing workshop. That is not just a 1 hour, 2 hours, it's a one whole week. So they call, okay, now we learn how to write an objective. Then somebody explain what is objective, what is this, and then research question. Maybe half an hour a lesson about research question, and then everybody writes the research question. By the week, end of the week, they will finish some kind of mock paper by learning step by step. So, and recently I also myself participate as an audience. It happened in Canada. So I went, it was very useful. I sit with them for 1 week, and then they teach, I learn, and I write. So how to write research question, they teach, I write research question. And something like, it can be done university level or high level, maybe your admin people or your lecturers can help you. So these are the 2 ways I know. Like one is workshop way, learning step by step. Once you learn that one, then you have your shut down and write. Something like, something you can call whole day you only write. So by that way we learn how to write. I'm also not perfect. We are learning. Everybody is learning. So this is like doing and learning. Your second question was? So forgot. Sorry. What was the second question?
The second question was about deciding on which topic or or idea to
Which field
cover
to come in.
as a novice writer.
Yeah. So for beginners, my advice, again, I'm telling it's not correct or there's no correct or wrong answer. I follow what I like. For example, my research interest is infectious diseases. So if I interested in that area, I get more novel ideas. Whenever I see a patient, I feel like something is coming. I always look at the things with a research mind. If I'm interested, so I advise. This is my personal advice. There's no anything like that. This is personal. You select the area which you like. Maybe you are a surgeon. You like surgery. So you think, if you like surgery, you think of research in surgery. So whenever you see a patient, you feel like research ideas. Or if you're an infectious disease person, if you like infectious disease, you try to find something in your area which is you are interested, so that you will have a lot of novel ideas. Yeah, but don't repeat. But when the other important thing, when you are interested in particular area, you read the publication in that area. Then when you're reading, there's a part of the publication is a gaps or limitation. So most of the time, my research area is coming from my interested area, and after I reading the gaps identified by other researchers, I said, it's a good gap. Why should I try? Why should I should not try? I get that gap and then learn more, study more, and make sure nobody has done anything. Then I jump into quickly and start doing that research. That's a very, very novel way.
Oh, very interesting answer and very practical actually. And Dr. Asri, we got some idea for improving the writing skill, either for academician or student. The program you mentioned previously actually very interesting, simple but very practical to improve our skill. Probably we could make a similar program like this at least twice a year, and sharing knowledge, just shut up and write, right? And the secondly is how to choose which field we are coming in, whatever you like, because I experienced it. What did you say before? Like whenever I like certain topics, then the novelty just come in from our head. Oh, this is the gap, and this is the interesting thing to explore more. And because I experienced, I just amazed with this answer. Thank you so much, Dr. Sukri. If there's any other discussion, oh, yes, please. Two more.
Okay, Assalamualaikum Dr. Shukri. My name is Selvi Hubaya. I'm student in Master of Public Health. My question is there a requirement for how many citation must be in the journal that we will submit? Thank you.
Number of the citation for certain journal we have to cite whenever we submit our article.
Citation, right? Yeah, so it is depends on the journal. Some journals says 40, 50, some say, no limitation, but I don't waste much of my time to put hundreds of citation unless it is a systematic review. So you cite the relevant one, updated one, latest ones, and also don't forget to cite, for example, you are submitting a paper in journal A, just look for that journal article, cite them. That is important, but number is not decided by, whatever you maybe write from others, cite them. But for example, one sentence has 100 citation, you don't want to put, you just put relevant one or two, that's fine. And some journals are very strict, you can have maximum 40, then stick to that. Other than that, there's no any things to be considered like, yeah. So don't waste your time again putting the hundreds of citation if not needed. Thank you.
So it's depending on the journal regulation, right? But I have a concern in how many journal we properly cite from from how to say this, the article published from the journal we submitted into. I mean, how many journal it properly cited?
Not like how many, but I would say at least some.
At least some.
Some. Then only you can tell indirectly to the editor is relevant to the audience of that journal. So the chances of considering at least reviewing is high. So that is one indirect way of telling. We cite because it's relevant, because relevant, so you are citing. For example, you have something to say in discussion that has already some good support publication from that journal, also from many other journals. Then I give priority to get that journal citation into my paper. Then, for example, it get rejected. Then I go to second, I change the citation to according to that second journal I'm submitting, something like that.
Okay, thank you. Thank you so much. Oh, there's question. I didn't see. Oh, I might read it. Thank you for the excellent presentation, Dr. Sukri. I'm sorry, this is slightly off topic, but still relevant. I have a specific question regarding a book chapters. I was recently invited to contribute a chapter to a volume of Intake Opened. While we are vetting journal using metric like SGR or Web of Science, I find that assessing the credibility and indexability of this book chapter is forward. Given this invitation, what systemic approach should I take to verify the academic integrity of this project? Furthermore, how can we determine if a book volume will be genuinely indexed in reputable databases, as opposed to merely being hosted online, to ensure that my contribution will be properly recognized for my academic portfolio? Dr. Resna, this doctor.
Yeah, it is very important, very interesting one, because I can say, the the what you call sometime, the kind of what I can, how to phrase, um uh kind of publication mafia is there. I always get hundreds of invitation. You are this, maybe I published 10 years back. They say, your recent publication very important, very interesting, very then can you like contribute to our chapter of this book or something like that. So yeah, then your time is important. Because someone like what we call, some publishers, they want to make money by writing books, and then indirectly push you to contribute your time to write something for them, and then ultimately they will get some kind of incentives or these things, and you will end up getting nothing. But when you are invited to be a chapter writer or writing a chapter for a book, that is good. Number one, you have to check who is the publisher. So publisher, the number one is the publisher, and then topic, which is whether it's relevant to you. Because book chapter, again, writing a book chapter may take maybe couple of months. So if whether it is worth for your time, in order to, what is the feedback or what is the outcome you get, right? So don't contribute your time, effort to profit someone and you will get nothing. So try and look at smartly. If it is like, a lot of publishers like Elsevier or some reputed publishers, they want to publish, you are invited, that is good. If sometime like random invitation, they just, randomly look at the, publications, and based on that, they just approach you, and, then if you look at the, publisher's name, there's nothing, no reputation or no anything, then better not to go and, waste your time with that publishers. So that is mostly maybe they are profit oriented rather than service. But if it is relevant, yes. If it is your field, yes. If the publisher is an authentic publisher, yes. Otherwise, time, no. And then some other publications I have encountered in the past also, they said, this is, we are good, this and that. And in the end, they said, can you pay something to publish this one? Such, you spend the time, you do the research, you write, and then they publish, they have all the copyrights and all, but still you need to pay for them to publish. So that is not appropriate. That is all business minded, I guess.
Thank you for the explanation, Dr. Sukri. I think it's clear but already. The concern about writing book chapter from Dr. Isna's question. Any others? Oh, one more. I think will be the last discussion.
Hello, Dr. Sukri. I have a question because probably you explained about the primary data research, but in our context, in a situation where in LMIC, probably we have the idea, but not the infrastructure to conduct the primary research. And so there probably we can do a narrative research, but probably there's a strictly only narrative review, not systematic literature review. Do you have any insight how we can publish or kind of like distinguish a strong publishable narrative review that it can be accepted in international publication? Thank you.
Thank you so much. So my understanding, you're asking about the systematic review and narrative review, and then you ask whether how we can improve the quality of narrative review so that it is publishable. Is that correct? All right. So yeah, narrative reviews are not the bad thing to do. It's a quick thing, and then superficially you analyze the thing and then write something in order to get some gap or ideas for your research or for your preliminary research. That is not a bad thing. But as far as you can come up with a new knowledge or new ideas from that narrative review, and which can be included. So before doing the narrative review, you have to make sure nobody has done such a thing, so that its novelty is there. So it's very simple, very straightforward answer. You need to spend some time and look for if anybody has done already, then don't repeat the same wheel again. So the basic thing, narrative reviews are good, quick, and then we do narrative reviews with the students to understand the gap quickly rather than wasting years with the systematic review. And then we publish. So and then also with the narrative review we have done, then if you see someone has done, then you can look at the data differently. So I look at the data this corner, you can look at the data the other corner, then that will be novel thing also. Like, it's not like a waste of time or waste of effort. It can be. And then my good advice, if you look at my publications, most of the time I have a lot of experts in my authors list. So I invite authors, those who expert, that make a venue for me to learn from them. Like their review, they give me a good feedback from their review. I learn, and also it is very important. Maybe I don't know whether it's ethical, but if these experts are like in your authors list, that is kind of positive remarks to the editors. This group is very strong group because this group has these people, so they have published tremendous amount of work and publication. So that is also one thing. I don't know whether ethical to influence the editor saying that we are very strong people, though the first author is a very junior person, but in the group is a very strong backup. So again, I would try to take this time to help, tell you one thing. I published my second paper in long time back. So I was a first author. It was a very strong paper. It's about in Malaysia. When I was in Malaysia, it was a tobacco control paper, and I learned and I did a lot of what they call statistics analysis, more complex analysis, and we submitted. Then it was very important analysis we did, and we spent a lot of time. And then in my in that group of people, maybe 10, 12 people were there. And out of that, the internationally recognized statistician was there. And then, but I was doing all the statistics. And then all of a sudden, one reviewer commented very badly. And then, and almost, I mean, he's rejecting this one paper. Then the senior people in my group, he wrote to the editor explaining this was wrong. This was wrong. This is the this. Then editor completely ignore the reviewer's comment and then accept the paper. So this is can be done. So this because so many things. Try to get a gap, important new thing, submit. When you do anything, you collaborate with other people. Don't do alone. An expert should be there in the group so that they can help you in order to, sharp you in order to thinking, writing, and everything. And also indirectly help you in order to get accepted at least or pass through the editor's point of view. So collaboration always important.
Oh, wow. So the answer is very clear, and I heard that Dr. Sukri also made the conclusion at his last sentences. To make it clear, Maya, it translated into Indonesia because this is very important. So, mempublikasikan ke naratif review jurnal itu merupakan hal yang bisa kita andalkan di Indonesia karena limitnya funding atau pendanaan. Itu sangat mungkin dilakukan. Caranya adalah dengan yang penting adalah menemukan novelty atau gap knowledge yang mau kita isi melalui naratif review ini. Yang kedua, ini juga mengisi cara kita untuk mulai berkolaborasi dengan expert. Jadi ketika kita menulis topik tertentu yang kita sukai, expert itu kita coba kontak untuk berkolaborasi menulis. Ini akan membawa sense positif jurnal kita atau writing artikel kita, manuskrip kita bisa diterima. Karena expert punya reputasi yang sudah lama dan diketahui oleh editor gitu. Kemudian yang terakhir tadi yang saya baca selain kolaborasi, kemudian positif impact dari kolaborator, saya kira itu ya. Yeah, I think that's all. And for today's presentation and discussions. So we are heading to the end of the session, today's sessions. Lastly, on behalf of the committee, Dr. Sukri, I would like to express our sincere gratitude for sharing your knowledge, experience, and valuable insight with us today. We would like to thank to all of the committee, all lecturers, guests, all participants joining us on site or online for your attention and participation in this guest lecture. At this point, I will be hand the program back to the MC. Thank you very much and have a great day.
Thank you to our speaker and moderator for the insightful sharing. And now we would like to present of appreciation in the form of a certificate to our speaker. And please join me on the stage, Dr. Sukri Zawahir and Dr. Chandra Dewi Payana Hamdin. And also to present the certificate, we would like to invite Dr. Astri Ferdiana. I will guide it with 3, 2, 1. Akan saya pandu dalam hitungan ketiga, 2, 1. Once again, please give applause for our speaker and our moderator. Ladies and gentlemen, as we reach the conclusion of today's workshop, we would like to express our sincere appreciation to all speakers, moderator, and participants. And everyone, don't forget to scan the QR code displayed on the screen for the certificate. Untuk sertifikat peserta dapat